All righty then. All righty then. Let's see here. Hello, 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 my friends. Jill Osborne, Interstitial Cystitis Network. It is time for yet another support group meeting. Hold on, I'm just trying to get Facebook all set up here. I do not understand what's happening with Facebook right now. Facebook, you're so annoying. The technology is so annoying. Hello, Facebook. I see you. I'm just trying to make it work. Hold on one sec. Okay. Hello, Stephen Bambi. Nice to see you. Bambi. I had a childhood friend named Bambi when we lived in Bakersfield. All righty. So here we go. All right, everybody. Hello, Jill Osborne, Interstitial Cystitis Network. It is Sunday, November 7th. Means my dad's going to be 99 years old by our next meeting. Just crazy. Okay, let me see. How are our lights doing? Are our lights okay? Looks dark. Is this dark? Hi, Jeannie. Nice to see you. Hello, Lisa. Nice to see you too. Nice to see you too. Why is it dark over there? It's a beautiful sunny day, huh? Let me do an experiment here. Whoa! Let me pull off my to-do board. That better? This is one of my to-do boards for the IC network. The other one's on the other side. All right, that's better. Well, how is everybody feeling today? The gorgeous sunny blue day here, but they told us we're gonna have 4 inches of rain tomorrow. So, and the good news, our evacuation bags and suitcases have been unpacked. Fire season is over. Woohoo! Yes, baby. Oh, thank God. It's early this year. And so what tests do you need to rule out other bladder issues? Honey, there are a lot of different tests that they can rule out. They can obviously do urine cultures to see what's going on with your urine. They could do a urine cytology test to see if you might have bladder cancer. They can do a urodynamics that would test how your nerves are working. They could do a voiding cystogram to see if urine is going the wrong way. Urine is going up instead of down. Those are and just a basic cystoscopy, just to look in your bladder, just see if there's anything funky going on in your bladder. That's important because you'd be amazed at the things that can happen in the bladder. Like bladder stones. Norma says, hi, Jill. What do you know about COVID-related IC and treatment? Well, we're the only people that's kind of studying it right now, along with researchers up at Beaumont University. I've been doing a COVID IC research study now for over a year. And what that COVID study shows is that about 75% of IC patients who do get COVID experience a worsening of their symptoms. And about 25% of those patients go into what we would consider a very, very severe flare that doesn't appear to respond well to regular flare treatments. The research believes that it is an inflammatory reaction in the bladder, that it is the cytokine storm that's affecting the urinary tract, and that is what's driving that bladder wall flare. I'm hoping to have more information that will help you soon. Because it's something that a lot of the doctors are finally talking about. Jennifer, thank you so much for 100 stars, 10 weeks in a row. Okay, Pamela says it's freezing up again. I got to tell you, Facebook, they just changed all their streaming stuff. My frame rate's 29 frames per second. The current frame rate is too low. Please set the frame rate to 15 to 60 seconds. Like, okay, how the hell do I do that? Let me go to settings here real quick. Stream settings. You can't do that. Let me go to my dashboard. Let's see if there's anything on the dashboard here. You know, I feel like whenever I turn my head to the side, you guys see my face sagging. But it is what it is. I'm getting older. Facebook guys, I'm so sorry. I just it just doesn't tell me how to do it. And I'm not stupid. I mean, I'm pretty good at this stuff. Whoops. So Jeannie says, for those of you on Facebook, that if you just rewind it a minute, all the freezing will go away. Thank you, Heather. Thank you very, very much. Anne says her Facebook is okay. All right. Cool. So you know you're a support group leader when you're getting ready for bed. Last night at midnight, I was taking a shower when I had an idea for an article. What did I do? Put my pajamas back on, came over here, and I wrote a new IC article for an hour and a half. And earlier I was just like so angry because it's like Saturday and I was doing IC stuff. And it's like, Jill, you have to read books. You got to get out of IC for a day. But, sometimes it's just there. It's just there. So anyway, let me introduce myself. Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the national IC support group leader. I do support group meetings fairly regularly online through Facebook and YouTube. We are simulcasting right now on YouTube. If I'm looking here, I'm looking at YouTube. If I'm looking over there, I'm looking at Facebook. And you're on two separate streams and two separate internet services. So there shouldn't be any conflicts here. Y'all should have a good stream quality. We'll hope. We will hope. Kimberly says, my 3-week flare finally calmed down with Valium. Woohoo! Yeah, we'll take it. Well, normally when I do these meetings, I do about a 30-minute little mini lecture, and then I will take your questions for however long you have questions. Sometimes we go into Zoom, sometimes we don't go into Zoom if you would like to talk to me. Anne says, I'm afraid to have a cystoscopy. They hurt even if you're normal. You can... Okay, hold on a sec. Anne, you're afraid of a cystoscopy because they hurt. And even if it's normal, you can still have IC. Okay, so here's the deal. A cystoscopy is what I call a looky-loo. It's just, they just numb your urethra, stick a scope in, take a look around, pull it out, you're done. It is a quick 5-minute procedure. I've had several of them. And the only issue with this having a cystoscopy, well, there are two issues with cystoscopy. Number one, your urethra potentially is going to get fairly stretched out and uncomfortable, which is why peeing afterwards is uncomfortable. You're going to notice the first couple of times you urinate, anytime they put an instrument in your urethra, whether it be a catheter or a cystoscope, your urethra is not going to be happy with you, and it's going to be uncomfortable when you urinate the first couple of times. But that said, I don't like guessing. I like facts. I think if you've been suffering, especially if you are in significant pain, if your pain is getting worse rather than better, if you have visible blood in your urine and they're not sure, where that's coming from. I mean, there comes a time when you have to let somebody look. You have to let somebody look in your bladder, right? Otherwise, you're forcing them to guess. And frankly, you deserve more than a guess. You deserve more than a guess. You deserve facts. You need facts. You need to know what's wrong with you. So, and of course, the other issue with the cystoscopy is really, 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 really rare, especially for an in-office cysto, is sometimes if they push the cystoscope in too far, they might scratch your bladder a little bit. And I just working with a patient last week that happened to. And it's like no biggie. I mean, the bladder will heal. But that's really about the expertise of the doctor who's doing it. I mean, if normally that doesn't happen. It never happened to me. But it reminds me of an IC patient who is sometimes on our Facebook side, who is a member of my original IC Redwood Empire support group, who was self-catheterizing. And, your urethra is like this big, right? Your urethra is like the size of your little finger. It's small. Well, she put 10 inches of a catheter right up into her bladder so far that it got stuck. She couldn't get it out. And so you got to understand anatomy a little bit more. And that was obviously she made a mistake. She called me from the ER and we helped, and the doctor got it out. It was not a big deal. But anyway, just the concept here is anytime you put something up your urethra, you're going to stretch your urethra. So, but here's the deal. What do you do if they look at your bladder, like they looked at my bladder, and it's normal? It's normal. My bladder, entirely normal. I got a baby bladder. Uh, Nothing wrong, physically wrong with my bladder. So does that mean that I have IC? Well, and ultimately, this is where we get into kind of semantics, but we also have to understand that IC is a grab bag diagnosis. It's what doctors will often diagnose somebody with if they have frequency urgency pain, but they don't understand where it's coming from. They go, oh, you know what? Maybe you've got this incurable bladder disease called interstitial cystitis. And they give you the diet and they give you Elmer and they send you on your way. But a diagnosis of IC is not particularly meaningful because it does not reveal what the underlying problem is. So, for example, if you have a bladder covered with red bloody wounds, you have Hunner's lesions. That's called Hunner's lesion disease. Okay, so that's clear. We know what that is. We know that those wounds have to be treated. That's only in 5 to 10% of you. But what if your bladder's normal like mine? Does that mean your bladder's a problem? The answer is no, probably not. Probably not. And that is why we call IC a pelvic pain syndrome, because structures outside of the bladder are usually involved, if not driving everything. And so it's really challenging here when you're given this bladder disease diagnosis, but your bladder looks normal and it appears normal. And we have to get you and your doctor to start looking beyond the bladder. We need to know what's going on with your pelvic floor, for example. If you look at the American Urology Association guidelines for IC, it's crystal clear. Pelvic floor assessment should be done at the very first appointment. And if you have tight pelvic floor muscles, you need to be going to physical therapy. If you have chronic overlapping pain conditions, if you have IC, IBS, vulvodynia, TMJ, fibromyalgia, migraines, well, you're in a completely different situation. This is also my subtype, because what that means is that you basically have a central nervous system sensitivity, that your central nervous system is driving these multiple pain conditions throughout your body. It's characterized by having very, 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 very sensitive skin, right? So we always have to take a step back if your cystoscopy is normal and go, okay, good, great news. My bladder looks good. So why am I wasting time doing bladder therapies? We need to look beyond the bladder. Do you have a fibroid tumor pushing on your bladder? Do you have endometriosis attached to your bladder? Do you have a bad hip? Do you have a labral tear? Do you have a bad SI joint? Do you have a Tarlov cyst coming off of your spine? Do you have pelvic congestion syndrome? There are a lot of other conditions that can cause the bladder to give you frequency, urgency, pressure, pain. My goal in doing these meetings is to try to open some of those doors and open some of those windows and get you looking at some of those things. Because even the American Urology Association says, hey, listen, if you're not responding to bladder therapies, if you're getting worse rather than better, if you're in severe pain, we got to stop for a moment, take a step back and reconsider the diagnosis. They don't want you to do bladder therapies if they're not helping you. Why would you spend $10,000 paying for Elmeron if Elmeron has never helped you? And of course, that's what happened 10 years ago, 15 years ago, 20 years ago. But now we know to look beyond the bladder, and that's exciting. All right. Jennifer says here, hold on a second. Let me move my mouse. My cystoscopies have been painless. Awesome. That means you got a really, really good doctor. Here, hold. Let me scroll back here. What? Facebook's letting me scroll back. Jennifer says, thanks to your wonderful information, I have no pain for over a week. You've helped me more than any of my doctors. Yay. Thank you. Nancy is talking about a Valium suppository. Valium is a vaginal Valium suppository. Delivers a muscle relaxant directly to your pelvic floor through your vaginal wall, and they work. Now, you guys, there is a difference between a plain office cystoscopy that I call a looky-loo versus a hydrodistension with cystoscopy. The hydrodistension with cystoscopy is a completely different procedure. That's where you've gone for an outpatient procedure in the hospital. They put you under anesthesia. They fill your bladder up with fluid, stretch your bladder a little bit, drain it out, fill it up again, stretch it again, drain it out. Then they put the cystoscopy in. That's a totally different story. That's the old way that they used to diagnose IC, but even that's now been thrown out as a diagnostic methodology unless your diagnosis is in doubt. So to make a diagnosis of IC is no longer required to have a hydrodistension. However, there comes a point again where if they don't quite understand what's wrong with you and they want to take a closer look at your bladder, especially if you've got really extreme symptoms and blood in your urine, then yeah, they might want to do a hydrodistension with cystoscopy. So Elizabeth says, my cystoscopy was incredibly painful. Lidocaine does not work well for me. I'm kind of glad I was awake for it because going to the hospital and getting anesthesia would be more expensive. How do you know if they scratch your bladder? You would be bleeding, hun. You would have blood. Maybe not a lot, but a little. If you have a hydrodistension with cystoscopy and they rupture your bladder because they overstretch it, which was very common 10 years ago, it's not common now because they don't use as much fluid. But years ago, it was fairly common. They'd really overstretch the bladder. They thought the more you stretched it, the better. And unfortunately, for some people, that did rupture their bladder. So, but the bladder heals and it happens. And I'm not excusing it. The whole goal now with therapy, according to the AUA guidelines for IC, is to never let that happen again. But if you ever have a hydrodistension with cystoscopy and you're sent home from the hospital with a catheter, that means that they ruptured your bladder or they damaged your bladder in some way. Elizabeth says, I consider a cystoscopy to be torture. Listen, if you've got a uber sensitive urethra, if you've got really, really, really tight muscles, vaginismus, something like that, yeah, having anything put in your urethra is going to hurt. It has the potential of hurting because those muscles are really, really locked down tight. Pamela says, I've done physical therapy for over 12 years. No help on it. Well, okay, so Pamela, in this great book, right, that I keep talking about over and over and over again, I'm just going to rave about this book consistently. Concept number one is when you go to physical therapy, are your muscles tight, right? Are they tight and dysfunctional? And I would assume since you've been doing it for so long, they're tight and dysfunctional. But the question then is why are they going back into tension? Normally, when you do pelvic floor physical therapy, your muscles relax for a period of time. They flatten them down, they release them, they relax them. But what fascinated Dr. Weiss in his pelvic pain clinic is why did the muscles get tight a couple days later, or a week later, or a month later? Why was the tension always there? And that's when we have to look at something else that could be putting pressure on your pelvic floor that physical therapy can't fix, like a bad hip, a bad SI joint, a bad knee, a bad foot. One of our members has extremely tight muscles. Man, no matter what they do, her muscles are locked down hard like concrete. And in her case, physical therapy is not substantially working at all or substantively working at all. And there's an important reason why, and that is that she has a club foot and she doesn't walk normally. And because she walks abnormally, she's absolutely putting strain and stress on her pelvic floor on one side, which is creating this foundation for long-term chronic pelvic floor tension. Pamela said, this said you need a mental health doctor. My doctors then sent me to another doctor and then the next doing nothing after driving. Pamela, I'd love to talk to you. Absolutely love to talk to you this week. If you'd like to give me a phone call, like on Tuesday, on Wednesday morning, I'm speaking to an Israeli group. I'll be doing a presentation for them. And then on Thursday morning, let's see. Thursday morning, I'm training a bunch of attorneys about IC that are part of the Elmeron litigation. So Tuesday's going to be the best bet, or Friday's going to be the best bet if you wanted to reach me this week. I mean, the other thing that we always have to consider are other structures and organs. Again, fibroid tumor pushing on your bladder could cause this. Pelvic congestion syndrome could cause this. If you have a feeling of heaviness in your pelvis as the day goes by, like literally when you wake up in the morning, things are fairly good. But as soon as you sit up, and then as soon as you start walking, and then as the day goes on, you feel heaviness, heavier, 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 until finally you feel like you're carrying a bowling ball around in your pelvis. That's pelvic congestion syndrome, and that is fixable. That is fixable. And so if you just are baffled, you just do not understand why you have this pain, there's an important book to get. Stay. Dr. Elise Day from Harvard was one of the editors in this brand new book that was released this year called Facing Pelvic Pain. This is the book, man, we needed this book 20, 30 years ago, because it literally goes through every other issue which can trigger all the symptoms of IC and pelvic pain. What musculoskeletal problems can lead to pain? What GI problems can lead to pain? What urogenital problems can lead to pain? What here, hold on. What rheumatological, neuroinflammatory, and vascular, like pelvic congestion syndrome, can lead to pain? And which neurological problems can lead to pelvic pain, like MS, things like that. Nora says staying 15 years on the IC diet has saved you. So, and let me just go back here too. This book is free on Kindle Unlimited. Like, seriously, no excuses. It's free. But I really strongly recommend this. We have got to be our own advocates here. It sucks that when you're feeling awful, you want somebody to come in and rescue you, but they can't. You have to rescue yourself. And a lot of this has to do with you understanding your body and how things work in your body, and trying to correlate other conditions you might have and how that relates to this, other symptoms that you might have and how that relates to this, right? So this book is insanely good. Facing Pelvic Pain by Dr. Elise Day, who actually dropped into our Facebook meeting on Thursday. It was very cool. Always nice to see her. Pamela, my doctor said the same thing. The first urologist I went to, Dr. Mark Klein, who I adore. He's retired now. He's literally the best urologist in Kaiser nationally, according to his ratings. I was like one of his first IC patients, and he sponsored my support. I was the only IC support group sponsored by Kaiser Permanente for a decade. And he said I taught him more than he taught me, and so I brought in the materials that I found. He showed the materials that he found. And yet, even then, even though he was very, very receptive, at that very first appointment, he also suggested that I go to mental health. He wanted me to learn about mindfulness. And I just, in a very kind way, I said no. I said, no, I'm not interested in going. I have a master's degree in psychology. I'm not interested in going to learn about mindfulness. I can't sleep at night because my bladder's screaming at me. Please help me with my bladder. And I was in too much pain to be receptive to that. But he was absolutely right, in the sense that because he saw that I had IC, IBS, vulvodynia, TMJ, and others, he saw intrinsically that I had chronic overlapping pain conditions. We didn't know what it was called back then. They didn't call it that back then. But he also knew that the central nervous system, and calming the central nervous system and getting that nervous system less sensitive focusing on calming nerves throughout the body is critical. And ultimately, that begins with mindfulness and you understanding that if you're anxious, your brain's going to intensify your pain. That's part of fight or flight. If you got out of control anxiety, that's only making your pain worse. We have to learn to control the anxiety. We have to learn, understand the influence that anxiety has over pain. And you get stuck in this vicious circle. The more anxious you are, the more pain you're going to experience. And that's part of fight or flight, you know? It's quite interesting. So, anyway, I wanted to talk a little bit about the holidays because the holidays are coming up sooner rather than later. In fact, I bought my Christmas tree yesterday. Um, and it's currently in the garage gassing off. um, you know, um, the holidays have not been as, I'm going to say, stressful during COVID. You know, if we were not in COVID, IC patients would be flying around the country to go see family members and enduring the stress and strain of traveling and having to explain IC and pelvic pain to everybody else. And there's a burden associated with that. And then, of course, you have to navigate food. Are you going to your sister-in-law's house and she doesn't believe in diet? What do you do if you're going to grandma's house and she's making lasagna and you know lasagna is going to kill the hell out of your bladder because you have Hunner's lesions? You know, navigating the holidays is hard. It's hard because you're giving up control to a certain degree. I mean, number one, traveling is always going to be challenging, especially if you got pelvic floor tension. Um, uh, and then throw in food, throw in stress, all that sort of stuff. The holidays are kind of a recipe for flares. But that said, we can't give up on the holidays. Holidays are very special. And just because we've got pelvic pain, that doesn't mean that we are not allowed to celebrate the holidays. But we've got to do it in a very proactive way. And that means that if food is an issue, we bring the food that we can eat. Or we eat ahead of time. If traveling is an issue, we bring the holidays to our house so we're not traveling so much, or we modify that trip. I mean, if you've got long-term pelvic floor tension, the worst thing you could possibly do is get in a car for 8 hours and drive. The odds are you're going to have a pelvic floor flare by the time you get there. Of course, you can prepare yourself by bringing some muscle relaxant with you, maybe bringing a chair cushion like this one that I'm sitting on, right? These are the Caustics cushions. If you've got a tender pelvic floor and or a vulva and or tailbone, et cetera, there are some ways of making traveling a little bit more comfortable. But if you're going to be doing car driving, you got to do a little bit of planning. So you got to have the cushion. If sitting is hard, you're probably going to need to stop every hour or two, get up, walk around, do your stretches. If there's any opportunity for you to medicate with a muscle relaxant during that trip, that would be really, really helpful. Of course, if you're driving, you can't pre-medicate, and so that's kind of tricky. That's when having travel johns in your car is a really, really, really smart idea. Where are my travel johns? So these are travel johns. I have them in every car in the family. I will tell you, I've never had to use them, but it's great comfort to know that I have them. So this is what pilots use. If there's no, if it's a small pilot and they're flying a long distance, they literally just pee into this. The cool thing about the travel john is it fits comfortably right over your body. There's powder in it. You pee into it, immediately solidifies. You just roll it up and throw it in the next trash can, right? So having travel johns on hand is helpful. Of course, one of the tricks of the trade is if you do need to pull over, you open the front door, you open the back door. Hopefully there's trees on the other side. You're blocked from each side, and you can usually pee fairly quickly there because, we IC patients, when we need to pee, we can pee really quickly. Because of COVID, the really good bathrooms at Starbucks are now closed, and that's tricky. Finding restrooms on the journey, it might be a little bit harder this year. So again, yet another reason to have travel johns. Um, um, I don't need to go into the COVID stuff. I mean, I think everybody, there's a lot of division in this country about this. Um, in my opinion, given what we know about what COVID does to IC patients, I think you need to have an overabundance of caution. So I would certainly be wearing masks when you're going to gas stations and going into public restrooms. It is what it is. And when you get to the other side, wherever you're going to be, hopefully they're being attentive. COVID is on the rise again up here in my county. It's increased 10% in the last week. So we're again being very, very careful. Let's talk about plane travel for a moment. Um, um, like if you want to tell me that if you want to put me into a flare, all you got to do is tell me I have to get on a plane tomorrow. I will tell you right now, my body has a very strong reaction to flying. It doesn't like it. And one of the reasons why it doesn't like it is because it's a 2.5 hour bus ride to the damn airport, and the bouncing of the bus kills me, right? And then the other thing too is anytime you have a perception where you're not going to have access to to the restroom when you're on a plane, that's like you immediately have to pee, right? I mean, all you have to do is say, "Hey, you're not going to be able to use the restroom for the next 30 minutes." And you're gonna immediately feel the need to urinate, and then holding it for that 30 minutes is challenging. When I do fly, I have a couple of different things I do. Number one, I had carry our medic alert card. We have an IC network medic alert card that says restroom access required. Let me see if I have one. Hold on. Yep, here it is. And this was very, very true. This is very, very true 20 years ago when my IC was really bad and I was flying. I always, when I made my reservation, I let them know that I had a disability called interstitial cystitis, and I wanted that on my reservation. Then, when I got to the airport to check in, I at every single step, every person I talk to, get on the way to the plane. I have a disability. I have interstitial cystitis. I may need restroom access. And I whipped out my card. This is our medical alert card, our restroom access card, right? So it says the holder of this card has a medical condition, interstitial cystitis, prostatitis, or pelvic pain syndrome that requires frequent and urgent restroom access. It is difficult, if not impossible, for this patient to hold it without enduring severe pain and or bladder spasms. Please provide restroom access to this patient. Your cooperation is greatly appreciated. And then on the back, it explains what interstitial cystitis and prostatitis is and why this is important. So if there's anybody who's going to be traveling and you don't have this, I will send you one for free. I will absolutely send you one for free. All you need to do is email me icnetwork@mac.com with your mailing address, and I would be more than happy to send you one of these cards. If you want a couple of these cards, you can buy 3 in our store for like $2.99, right? You can buy 10 or 20 for $9.99. But anyway, if you want one of these, I am more than happy to send you one for free. Okay, so I've checked in at the gate. Well, listen, I've checked in when I've walked into the airport. I've gone through security. I've now gotten to the gate. And when I check in down there, I just let them know, hey, I've got this disability. I may need restroom access. I could really use your support. And they're not awful about it. They're like, okay, we'll see. Can't guarantee it, but we'll see. Then when I get on the plane, and go to my seat, as soon as I can, I find the flight attendant for that part of the plane, and I hand them this card and I say, "Listen, I just really need you to understand I've got this really painful condition, and if I need to urinate, I really need you to help me urinate." And only once, I mean, I would taken probably 20 flights since my IC diagnosis, maybe not that many, maybe about 15 flights, whatever. I've only had one flight attendant say no. The rest have said, "Not a problem." Now, picking your seat on a plane is important. Um, the best seat for me is a seat literally right next to the restroom. It's just I have no problem being in the only issue I have with sitting in the very, very back of the plane is that I get this weird tunnel vision, and I can see the length of the plane. I can see, like, we're in this tube, and I can see the plane go down and up that way, and that kinda tricks my eyes a little bit, so I just don't look forward. I'm looking at my iPad or my book or whatever I'm reading, right? But I love sitting right next to the restroom, like a row away. If I have to choose between window and aisle, I will always pick aisle because I wanna be able to get up and dart in there and get out of there. So then what's your P strategy? Um, uh, what I always did is when they started boarding and they started the boarding process for my section, I went to the bathroom. Like whoever I was with, just like hold tight, I'm gonna run to the bathroom, empty my bladder there, right? Came back, got on the plane. And you know that there's like a 25, 30-minute window where they're seating everybody. So I try to sit out for another 20 minutes on the plane in my seat, bam, to the bathroom one more time. I'm in that and, sometimes a flight attendant's like, "Girl, what are you doing? Get in your seat." I just again, if you're sitting right next to the bathroom, you can get in and they can't stop you. You can get in and out so quickly. I dart in, I dart out, I'm sitting. I'm good. Then the plane does its thing. You taxi, you go to the runway, you take off. And it's about a 20-25 minute window before they hit altitude where they take off the fasten seatbelt sign, get up again, pee again. What I found for me is that I never I went frequently, like every 30 to 45 minutes, even cross country, even all the way to London, which I did twice. Uh, I made sure that, like, every 30 minutes, I went in there and I emptied what I needed to empty because I didn't wanna get stuck with a full bladder and them hitting turbulence and turning the fasten seatbelt sign off. And I know that that's counterproductive to what some people say. They say, "Don't pee all the time," but I think flying, is important, because it gave me a sense of control, and it gave me a sense of calm. And the only time I had a flight attendant say no, I was flying back from a urology conference in Orlando, and, I really needed to pee. I mean, like, holy hell, mother of God, please help me. I need to pee so bad. But the fasten seatbelt sign was on because there's just a little bit of turbulence. And I'm just like sitting there, like almost crying, saying, "Can you please let me use the restroom?" She said, "No, no, you look fine. No." And I said, "Listen, if you don't let me use the restroom, I'm gonna pee my pants right here. I'm in agony." And and she kind of was like looking me up and down, like going, "All right, there's nothing wrong with you. You look fine." And that's where it gets really hard giving them context because they don't have a freaking clue what interstitial cystitis is. As far as they know, they just you think you're gonna go smoke in the bathroom, right? I mean, they really have no clue of the pain involved. And ironically, I actually had an American Airlines pilot show up in my office one day because he had IC and his was triggered when they stopped restroom access and he had to hold his bladder for 6 hours on a cross country flight. So, anyway, I'm just like crying. It was so bad. The pain was so severe. And she's like, "I don't get it. I just don't get it. You look fine." That's when I think that there's a moment when if you need to exaggerate a little bit to help them understand the context, it's okay in that moment. Eventually, she said, "All right, you can go, but If anything happens, the airline's not held accountable. I'm like, fine, not a problem. I like tear to the bathroom, pee, come right back down. And it's like, oh, thank God. Right. So, I don't want you to let your IC stop you. You just have to be really informed and empowered here. People need to pee on planes. It's okay. Now, worst case scenario, if you're really controlled, like what's a worst fear of traveling for me would be stuck on a runway for 10 hours with no access to the restrooms. There's been a lot of lawsuits about that. Again, what you can do is you can have a travel John with you. And if you're desperate, you really need it, you just get a blanket, put the blanket over your lap, drop your trowel. You can pee into this right on your airplane seat. I know that's extreme, but pain is extreme. There are times when you've got to be bold. There are times when you got to put yourself together. So you can travel with IC, but there's also a question of timing. In my family, my mother, God love her, my mother she was my travel companion everywhere. I brought her to all the AUA flights. All the AUA conferences. We've flown the world representing IC, right? I mean, she's 92 now. Let me tell you, that woman is the master of mother guilt. I mean, and so there were, especially early in my diagnosis, again, when I had a lot of pain, and it was a holiday and I was feeling like crap. And it's like, honey, she's like, Jill, come on, we got to go. And it's like, come on, you got to go. People are going to miss you. You have to come. They're going to worry about you if you don't come. You have to come make an appearance. Even though it was a 30-minute drive and the drive was agony and I was already in agony, I did that for many years. I mean, I did that for many, many years. Drove up to my sister's house. And there were some moments when I was so sick, I just had to go upstairs to her bedroom and lay down. I couldn't even participate anyway. And then I'd ruin the holidays for them because they'd all be going, what's wrong with Jill? And that was not healthy for me. And that was not healthy for them at all. That was not healthy. And then we had an episode where she wanted me to drive her up to my brother's house for 2 hours, and I was in a severe flare. And again, mom guilt's a powerful thing. I did it. And I was okay, of course, now we know I was having pelvic floor flares, which is why driving was so painful. I got up there, and again, I'm just in agony. And then they went out to eat, and I couldn't eat anything because I knew I had to drive her home, and I didn't have pain meds. And oh my God, it was just a disaster. So finally one day, one holiday, one Christmas Day, I woke up and I was just done. And she did the, come on, you got to get dressed. I mean, I was like 35 or 34 or whatever. I mean, I wasn't even a kid. But remember back then, because my IC was so severe, I really needed their help. Anyway, everybody started getting together. I started getting dressed up. I did get dressed up. I put my makeup on. I felt like crap. And then it just like dawned on me, you don't have to go. You don't have to go. You can stay home. It's okay. And I put my foot down. I said, nope, not going to do it. I feel awful. I feel absolutely awful. And it was very empowering to do that. It felt really, really good to be able to put me first for once, because I'm a single daughter, don't have the children like my sister does. And though the children, appropriately so, I'm not criticizing that. But my needs were always the least important needs in the family, kind of, so to speak. And anyway, just one day I just said, I can't do it. I'm not going to do it. I said, you can go, bring me back some food. That's great. But I'm going to stay home. And again, I got are you sure? That mom mind is a powerful thing. And I resisted, and I went back, took my clothes off, put on my jammies, got my heating pad, watched Avatar. There's Avatar or another long movie like that. And it just dawned on me that, you know what? It was okay for me to miss that. I felt so much better staying home. And so, and they all came home. We missed you. It's like, I know I missed you too, but it's okay. I needed this. This was absolutely the right thing for me to do. Um, that happened one other time when my cousin was getting married and I was in the wedding. I was supposed to be in the wedding party. I was just going to read a psalm, right? Down in Southern California. And my parents and my sister, and I were going, and again, I woke up that morning, I was just in agony. It's just like, "I can't do it." So they went without me, and then when they came back, they went, "Oh my god, Jill, thank the Lord you didn't go." And I'm like, "Why?" He goes, "Because the road was awful. It was like 10 miles of this very, very bumpy road. It would have destroyed you." Like, okay, whew, the Lord works in mysterious ways. So I just want you to understand that you have the opportunity to say no. Now, what's the best case scenario for the holidays is you bring it to your house and you do a potluck so that you don't have to cook everything. It's okay for you not to cook everything. You get to cook what you like, but ask everybody else to contribute. People can come together at your house, enjoy their meal, enjoy their togetherness and being a family, play the games, Jackbox. I played Jackbox TV last night for 4 hours with some friends. It was hysterical. Um, uh, bring them to your house, celebrate together. Hopefully, everybody will clean up together, send them on their way, and that's not traumatic for you. And that's the best case scenario. Again, COVID complicates things very tremendously, but try to bring it to them. Understand too that for the holidays, especially for Christmas, that every generation gets to do things differently. That and every person in every family has a different tradition that they like and they appreciate. Um, and so you don't have to do the same thing every year if you don't want to do the same thing every year. It's really important that you ask yourself, what would make this holiday meaningful for me? What would I love to do this year? What would I love to do this year? And ask everybody in the family, what could we do this holiday season that would make this really special for you? And gather together everybody's goals here and priorities here and make some new traditions. It's okay to make some new traditions. My big tradition is making Christmas bread, Scandinavian Christmas bread, which it's a family recipe that goes back generations. And I make about 20 loaves and send them across the country to other family members. That's my gift to a lot of people. So anyway, I just want you to be gentle to yourself. You don't have to push yourself. You don't have to force yourself to do something if you're not feeling well. That there are moments when it's okay that where you get to come first. There are moments when you get to say, this isn't the right time for me. There are moments when you get to say, would you like to come to my house because driving is uncomfortable? So I just want you to think about that. Okay. Now, the cool thing about Thanksgiving is the Thanksgiving Day meal is extremely icy friendly, with the exception of cranberry juice. Turkey, stuffing, all that sort of stuff. Go to town. Sauteed carrots, broccoli, whatever you love to do, sweet potatoes, mashed potatoes. The Thanksgiving Day meal itself is extremely gentle and low acid. You should be fine as long as you don't do the cranberry and as long as you don't do like a spicy hot cheese as an appetizer or a lot of alcohol. You got to be careful. You got to protect your bladder. And the same is true with Christmas. These traditional meals, except if you happen to come from a family that loves pasta, that's very tricky. My family normally like to make homemade lasagna the night before. I don't know why, we're Swedish, but go figure. You'd think it'd be fish, but no, it was lasagna for decades. But there came a point in time where we couldn't do it. It's just too rich and it was irritating. And so now our Christmas Eve meal is pot roast. Go figure. So, just a couple ideas on the holidays. We do have a holiday resource center over on our website, icnetwork.org. I would love to hear what your favorite ICE friendly um, holiday meals are. I would really love to hear what that is. All right, now I got to check in here. All right, so hold on a sec. I got a Facebook here. For some reason, it wasn't feeding me your comments. So let me look at here. CMB says she does home rescue installations when she's having a flare, and those home rescue installations are composed of lidocaine for the numbing effect, heparin for the coating effect, with a little tiny bit of sodium bicarb, which helps it be absorbed. CMB, just really understand you should never play with that formula. You need to stick to the formula that the doctor gives you, and you should never, ever assume that more is better, especially with the sodium bicarbonate, because it's the sodium bicarbonate that helps it absorb into the tissue. But if you use too much sodium bicarb, it could absorb into your bloodstream. So do not ever play with a rescue installation formula at home. Okay. Nora says, staying 15 years on the IC diet saved me. And so, what does that mean then? So, the fact that you were so diet sensitive points to the fact that your IC subtype 1 Hunner's lesions or IC subtype 2 bladder wall driven primary, right? That's the challenge here. Julie says, what supplements in your store would you recommend if you've had Hunner's lesions and had them removed? We'll be going in to have lesions removed for a second time. They are not as extensive as before. I'm on cyclosporin. I've done pelvic floor therapy, but I'm having spasms in your urethra and bladder after I have a bowel movement. It may be from the lesions, but generally this will happen after I've just eaten and food is disgusting. Julie, so literally the very first thing that came out to me as I was reading that, and the fact that you're having a spasm in your urethra after you're eating, is it sounds like you could have some estrogen atrophy. I can't tell how old you are because I don't see your picture, but remember that the urethra is kind of the canary in the coal mine when it comes to aging and estrogen loss. And so it's the urethra that's usually the first part of the urinary tract that starts to scream when your estrogen levels drop to a certain point. So I would have to wonder, number one, where your skin health is and if you are showing signs of estrogen atrophy. If your vulva's dry and your vagina is dry, then so is your urethra and so is your bladder. It's very cool that you're using cyclosporin. Cyclosporin is considered really on point for Hunner's lesions now. A couple of new research studies in the last couple of months have talked very successfully about cyclosporin therapy with Hunner's lesions. So I think you're doing the right thing there. That sounds reasonable. And the fact that you have Hunner's lesions and you've had pain means that your pelvic floor muscles have been tight for a guarding because of the guarding response. That your muscles are trying to protect you from that pain by getting you tight. So doing the pelvic floor physical therapy is important. But if you're having a spasm in your urethra or in your bladder, then that's not your pelvic floor. That's the smooth muscle of your bladder wall and your urethral wall. There's smooth muscle and striated muscle, skeletal muscle. So another interesting experiment might be to try a smooth muscle relaxant like ditropan or Detrol to see if that would help. But remember, guys, we always want to focus on the concept of cause versus effect. So the urethral sensitivity is the effect, but we always have to be focused on what is causing that symptom. So estrogen atrophy is a potential cause of that symptom. Tight pelvic floor muscles is a potential cause of that symptom. An infection in the paraurethral gland is a potential cause of that. So in your brain, as you're really thinking about your symptoms, you always need to like go, okay, those are my symptoms. What's the underlying anatomy which is driving those symptoms? You could spend a lot of time talking about therapies that control bladder spasms, but until we figure out why your bladder wall's spasming or your urethra spasming, you're going to be stuck there. And again, estrogen atrophy, pelvic floor muscle tension could be a potential cause of that. I don't think the lesions would cause urethral spasms like that. Becky says, I have a cushion in my car. I just flew, got the first time in 8 years. I wish I'd remembered to bring my cushion. Yeah, so we carry chair cushions in the IC Network store over at icnetwork.org. Just click on store and you can go there. We've been out of the cushion that I'm sitting on now for almost 2 months. Um, they're having shortages because of COVID delays. So they think the only cushion that we have right now is the waffle cushion. And I don't think I have. I love the waffle cushion. The waffle cushion is really good if you got pelvic floor pain, pain in your butt cheeks, glute muscles. The waffle cushion is awesome. Heather says, can you tell us a little bit about how you research IC? Do you read specific journals, for example? Yeah, sure, Heather. So, number one, I buy every book that I can find and I go through them. But on a monthly basis, really every 2 weeks or so, I go to the National Library of Medicine and I look at the new research. I also belong to several medical associations like the Society for Urodynamics and Female Urology, as well as the American Urogynecology Society. And so I get their medical journals here too, which are piled up over there. And I hate sending them to recycling. Um, we did I think I told you guys last week that one of the things that absolutely shocked me in research in the last month or two was we finally found out why Lyris was deprioritized. So Lyris was a medical device that delivers medication to the bladder for 2 weeks, 24 hours a day. The ultimate challenge when you have a bladder problem is how do you get medication to stay in the bladder? Because, hello, you pee it out like every 2 hours or so, you pee. So, how can we keep medication in the bladder for a long period of time? And so, researchers at MIT solved that. They created a new medical device that's like a noodle, a hollow noodle, and you fill it with medicine and then you stick it in the bladder for 2 weeks. And for 24 hours a day, 7 days a week, it delivers tiny but consistent amounts of medication to the bladder wall. So the first medication that they picked was lidocaine because their goal was to provide a new bladder therapy, a bladder pain therapy. So lidocaine was the obvious choice. But in the very first clinical trial that was done up in Canada, something remarkable happened. I think there were like 12 or 14 patients in that study, roughly half with Hunner's lesions, half without Hunner's lesions. They looked at their bladder before they did it, and they looked at their bladder after they did the Lyris therapy. And they were stunned that all of the Hunner's lesions disappeared because of this device. And it kind of makes sense because lidocaine calms nerves down, and we think that lesions are the result of neuroinflammation or viruses living on that nerve. So calming the nerve down with lidocaine kind of made sense. And I know that there's another much more complex biological explanation, but it was very, very promising. And patients got very excited and doctors got very excited. So doctors around the country they got all jumped on the Lyris research bandwagon. So the top doctors in the United States, Ken Peters, Rob Moldwin, Robert Evans, all joined this research process because to have a new therapy for Hunner's lesions is stunning. And especially something that healed them completely in just 2 weeks, right? The worst form of IC potentially now treated in just 2 weeks. It was mind blowing for everybody. And one of the patients in that study with Hunner's lesions called me and said, "Oh my God, my lesions are gone." I went, "How?" He goes, "This new thing, Lyris. I didn't know anything about it." Well, I called the company and I talked with the CEO of the company. Actually, he flew out to meet me and we had long discussions about it. And it was extremely exciting. So they opened up a new round of clinical trials focusing specifically on Hunner's lesions. Would Lyris treat Hunner's lesions as compared would Lyris treat pain? And the early studies in that were also quite promising. It's like, and I talked with doctors around the country who all saw lesions going away or reducing in number or size. But then Allergan purchased Lyris from the company that developed it, Terrace Biomedical. And Allergan is a behemoth, billion-dollar behemoth They're the guys who invented Botox, right? Tons of money, tons and tons and tons of money there. So they bought it because they could see that it's very promising technology, especially for chemotherapy, cancer to the bladder, or treating your recurring UTI. And they decided to reproduce the research studies and expand on them. They went to phase 1 studies and phase 2 studies. Phase 3 studies really get you close to FDA approval. And then one day, 3 years ago, it's gone. It's just gone. And they sent out a press release that said, we have deprioritized this. And it's like, what the hell does deprioritize mean? I had no idea what that meant. So I called the guy who ran the Lyris program and said, can you please tell me what's happening? This is important for patients. And he was very vague, and he just said, well, we decided that we're not going to do it. We've deprioritized it. And my interpretation of that was, okay, it's not going to make you money, so you're not going to invest money in it. That's what I thought. But these top IC researchers finally released their research data this summer or in September, and it failed. Lyris failed. That when they tried to reproduce the studies in centers across the country, and comparing it with Hunter's lesion patients versus patients without lesions, it didn't work. And about 200 patients participated in 2 different studies, and it just failed. And so now we understand why Lyris was deprioritized. I don't know why that happened. I do know that when Allergan started doing their own studies, that they had very different clinical trial recruitment. They wanted patients who were in terrible pain, who were not in pain care. And it's like, and I was talking to the clinical trial director at the time, or the woman who was coordinating that. And I went, you do realize that that's nonsense, that you're asking a patient in severe pain not to be using pain meds to do your trial. That's nonsense. So anyway, it's dead in the water. Who knows if it'll be resurrected in the future? Maybe there'll be another sort of treatment that they can use it with. But right now, Lyris is off the table. I have changed our website. I have explained that, and we've eliminated that as a potential therapy for IC. Would have been nice if they told us that a couple years ago. It's like very hush-hush. Cecilia says, can I take D-mannose for life? Seems like when I stop taking it, I get a UTI. Is there side effects? I'm not aware of any side effects with D-mannose. I mean, you need to do your due diligence, check with the manufacturer, go onto the internet and look for D-mannose side effects. D-mannose is a simple sugar that the human body does not use. When you take D-mannose, you're not going to gain weight from it. Your body can't use it. It's immediately excreted into your urine. It happens to have a receptor that matches a receptor on E. coli. Thus, if you have E. coli in your urine and you've got D-mannose in your urine, they attach together. The E. coli can now no longer infect your bladder wall, and you pee it out. So D-mannose is interesting, but in the research studies, proanthocyanidins are also considered to be remarkably helpful at preventing UTI. Proanthocyanidins, also known as PACs, also come from cranberry, but they're not acidic. And so there is one product that's very, very well known called Ellura, Ellura, which unfortunately is quite expensive. It's like $125 or so per month. But Natural Approach Nutrition, the company that makes Bladder Builder, was asked to make a more affordable PAC product, which they did, and it's called Prevent. Let me get it for you. So Prevent includes PACs and D-mannose. So, but if the simple D-mannose is working for you, and let me see, hold on, I just had it where the D-mannose that we have is called My Daily D-mannose, and it's by Natural Approach Nutrition, and it's just a powder. But again, not helpful for interstitial cystitis at all. But if you're prone to getting recurring UTI, then There you go. Now, the other question about recurring UTI is why, again, cause and effect. The UTI is the effect. What's the cause? Why is your body more vulnerable to UTI? And generally, the biggest risk factor is aging for a woman. That if you start getting UTIs after menopause, that's because your skin is dry, you don't have enough estrogen, thus, your bladder wall is more vulnerable. I attended a lecture on this taught by Dr. Anthony Schaefer years ago, and they've invested a lot of time studying women who get recurring UTI. And literally every day they took urine samples, they took vaginal swabs, etc. And what they discovered is that about 24 hours before the bacteria arrived in the bladder, it was in the vagina living quite happily. And the researchers then asked, well, what's happened to the vaginal defenses? Why is the vagina so vulnerable to UTI? And the answer came right back to estrogen atrophy. And so generally when an older woman, or if you're, post hysterectomy, or you're on chemical menopause because of endometriosis, like you're taking Lupron, um, generally what they might do is give you not only the correct antibiotic for your infection, but they might also give you a topical estrogen to use vaginally to improve your vaginal defenses. So again, cause versus effect. WSM, what is a good bladder cocktail for flare-ups besides water? A rescue installation. The rescue installation is with a coating like heparin or Elmeron combined with lidocaine or Marcaine. That is the epitome of a rescue because it rescues you out of a flare. If you are in a severe flare and you've done the flare rescue plan and it's just not working and you call your doctor for a rescue, um, that's perfectly reasonable to do. So it's a coating, again, heparin and Elmeron, or and something that will numb your bladder wall. That's going to be lidocaine or Marcaine, and uh, whatever other ingredients the doctors might want to put in there. Some doctors might put an antibiotic in there. Others might put Solu-Cortef in there, a steroid in there to kind of calm your tissue down. And of course, a little tiny bit of sodium bicarbonate. Over on our website, icnetwork.org, if you go into our bladder installation section, I have a list of all the published formulas. All the formulas used in research studies you can find right on our website, and you can talk about those with your doctor because there are lots of options, lots of variations. Doctors tend to have their own thing when it comes to rescue instills. Thank you, Cara, for the 50 stars. Cara says, this episode of the IC Network show should be called Extreme Peeing. Yeah. I have an alter ego. My alter ego is Princess Pee-a-Lot. We have Sir Toilette and Princess Pee-a-Lot. And when we had our live support group meetings in our chat room, back when we had chat rooms, we did a lot of a really fun kind of storytelling with Princess Pee-a-Lot and Sir Toilette. And then I think one of the funniest things we ever talked about was, where was the bathroom on the Starship Enterprise? And how would Mr. Spock approach having interstitial cystitis? I always thought, Elizabeth says, this is super gross TMI. I have tight pelvic floor muscles for trouble starting and finishing urine. There is one toilet at my work that is a perfect hyzer site for my body. I can just put the TP down on the seat, sit down, pee instantly, and normally finish. I'm a shorter person, and most toilets are not built for me. I took a picture of the toilet and wanted one like it installed in my house. Unfortunately, they had the toilet removed during renovations. No! Oh my God, that's awful. Ellen says, do you know anything about stem cell treatment for IC? I just got off the Elmeron this summer and I'm on Bladder Builder. I've had 5 or 6 flares since then. I'm on a pretty strict IC diet. I just started going to a new urogynecologist in Orlando. He said that there was one possible treatment. Oh, that the stem cell therapy. He started me on gabapentin this week to see if that helps. Well, stem cell therapy has been around for several years. I don't remember the exact research results. I know that I think some small studies were done that showed some success for some patients. Our challenge here is that there can be some controversy over stem cell therapy and the source of the stem cells. Dr. Elliot Lander out here in California at the Stem Cell Treatment Center in Southern California, what they did, they were the first people to do stem cell therapy for IC. And what they did is they harvested some stem cells from fat, from your own fat. So you basically go into the doctor's office, they would do a mini liposuction, they grab some fat, and then they would process the fat to isolate out, and they called it stromal vascular faction. And so they isolated out the stem cells, but then also a whole bunch of growth factors, because the growth factors are important because they're just part of how our body rebuilds tissue. And so, and then they used your own tissue to your own stem cells to ideally treat the interstitial cystitis. Their research results were not what we call durable. The research results were short term, that patients responded well to that type of stem cell therapy for about 6 months, and then it started to wear off and they'd have to go have it again. And so when they harvested your stem cells, they didn't just didn't do a one timer. They stored some of it so that you could go in and have another therapy. Of course, stem cell therapy is not covered by any insurance. It's what we call self-funded, especially in the research. So back when Dr. Lander was doing his first IC stem cell studies, it was $8,000 or $9,000 to do it. There was no, to fork up the money to be able to do it. I haven't talked to him in a while. I really should reach out to him and see what's going on. I don't think I've talked to him in 2 years. Diane says, I'm hoping to crack open the IC 101 book. Yes, right there. Have had IC for decades. Thanks to you, I realized Diet Coke flared me. Also had a really bad flare after a vaginal ultrasound, unbearable pain. Always feel like someone has kicked me in the lower abdomen along with burning with urination. Yeah, honey, check it out. Let's see if the book gives you some clues. It's interesting that the vaginal ultrasound gave you unbearable pain. Diane, I want you to go over to our website and I want you to read the blog about woman miraculously cured from Hunner's lesions. And it was about a woman who had severe Hunner's lesions and a severe bladder prolapse. And when they went in, and this is a published case study in a medical journal. When they went in to repair her prolapse, what they found was that one of the ligaments holding her uterus in place was gone, broken. And so her uterus had rotated back to forward. So the front of her uterus was pointing backwards, the backwards of her uterus was now forward. So what happened then is they repaired that. They reattached the ligament and they suspended her vagina and her uterus in the correct orientation. And she was miraculously healed of everything. I mean, this is like really you guys think about this for a moment. I mean, because this is so common in the IC patient population. You know, somebody tells you you got interstitial cystitis, you're peeing all the time, you can't sleep at night, you have pain when you walk, or you have pain when you sit down, whatever. And you're like a good you're a good girl or a good guy. You do everything they tell you to do. You follow the diet, you do all that sort of stuff. But it doesn't work. Why? Because it might not be your bladder. And in this case with this woman, it was never her bladder. It was never her bladder. It was a broken ligament that allowed her uterus to rotate, that created all sorts of problems in her pelvis, which traumatized nerves, traumatized blood vessels that caused the Hunner's lesions. But when they fixed it, her Hunner's lesions went away. Really amazing story. And we're just getting more and more of those studies. I got an email, I think after Thursday, from one of our guests, one of our members here watching, who had a severe labral tear in her hip. And so just understand that the bladder can be the victim of another issue. And it's your job to do your due diligence to try to understand if some of these other issues might be causing all of this, because we don't want you to live with pain for the rest of your life. We don't. We don't. We want to try to fix the underlying cause. WSM on YouTube says, most times when I pee, I have to concentrate and relax to let go. I understand at night because my body is half asleep, but during the day, yeah, because your muscles are habituated to tension, hon. There's a reason why your muscles are tight. There's a reason. Bad hip, bad knee, bad joint, bad foot, something. Or this could have been in childhood. You could have had vaginismus, or you could have a birth defect. Who knows? But if your muscles continue to stay tight, you're going to have trouble. You're going to have trouble starting your urine stream. That's a number one symptom of somebody with pelvic floor tension. Is that when you sit on the toilet or you stand in front of the toilet? Normally, when you pee, it's like that. It's like a muscle relaxes, a sphincter opens, and within a second, you pee. But if you're sitting there 5, 10, 15, 20, 30 seconds, a minute, 2 minutes, I've talked to some women who have to turn the water on for 10 minutes. You run water in the background to try to get you to relax. There are some people out there who cannot pee for 10 freaking minutes. Their muscles are so tight. So we got to work on that. We absolutely have to work on that. Hello, John. I don't know what alpaca is. I have no idea what that is, hon. Let me search it. ACALKA. Alpaca for kidney stones. Oh, it's potassium citrate. Yeah, that would be okay. Yeah, actually, there have been studies with potassium citrate and alkalinizing the urine. If you just Google potassium citrate, interstitial cystitis, and you can look at those studies. Okay, so it's not out of the ordinary, but you have to know how much, and you have to work with your doctor on that. Julie said, I had heparin installations once a week for 4 weeks. It was horrible. So, Julie, if you had a rescue installation and it put you into severe pain, that means that there was an ingredient in it that didn't work for you. Some patients are sensitive to lidocaine. And if it was a lidocaine that was making you scream in pain, then they would switch that over to the Marcaine. But with heparin installations, especially in the form of a rescue, you should walk out pain-free. So the fact that it gave you horrible pain says that there was something fundamentally wrong. My friend Evelyn, who is no longer with us, unfortunately, she passed away several years ago. She helped me found my first support group. Her name was Evelyn White. And she did home rescue installations for years. And then out of the blue, she got a new batch of pre-made installations from her pharmacy, and they hurt badly. And she couldn't, and she's like, what? This makes no sense. They had used saline instead of DI water. They used salt in it. They made a mistake when they made up her instills. And they used a salt solution, and that's what flared her. And so the ingredients matter, even the fluid. Generally, we're going to do better with a deionized water, just a plain simple water, as compared to a saline solution. Saline stands for salt. So anyway, they admitted they made them at the pharmacy, made a mistake. They remade it for her with the correct fluid, and she was fine. Angie says, get a squatty potty. Do you guys know what a squatty potty is? Here, I have one. Hold on. Let me go get it. Oh, where is it? Well, my squatty potty has done a runner. It's not where I thought it would be. It's basically what a squatty potty is. You have to understand the natural dynamics for, uh, um, urination and defecation. That when you sit on a toilet, it's a right angle, right? And unfortunately, what that does is that puts kind of a kink in your bowel that makes it harder for stool to pass through. But if you put your feet up on a couple of books, you fix that kink. It's interesting. Squatty Potty website, go over there. There's a bunch of videos. Squatty Potty is amazing. In fact, this is a great, oh my God, you want to create laughter among your family, especially your distant relatives? Send them all Squatty Potties. That's what my cousin did years ago. Like 5 years ago, we all got Squatty Potties. My brother, it was hysterical. Heather says, was there pain relief with Lyris? There was. There was. Heather said, how long are you allowed to safely take Cystax? Cystax is a little controversial. I know I did a paper on it like 7 or 8 years ago. I don't remember off the top of my head exactly what the date was. All I can tell you is Cystax was not meant for long-term use. Vicky, thank you so much for the 200 stars. Lisa says, hey, I have a question. I get bladder installations, which is instant relief. Good. I can self-cath, but the meds cost $600. My insurance won't cover it. I don't know what to do. I don't have $600. So Lisa, there are some compounding pharmacies that pre-make rescue installations. And it comes pre-packaged, and it's like $125 or $80, somewhere in there. The pharmacy that started doing that, oh God, who are they? Imprimis Pharmaceuticals in Southern California licensed it, prepackaged it, did it for several years. Then they released the license and they were bought by another company. There are a handful of pharmacies around the country who do make prepackaged rescue instills. Oh, what were their names? If you come over to our website and maybe go into the IC Network support forum and search for compounding pharmacy. God, it's just right on the tip of my tongue. I met all those pharmacy. I met like 3 pharmacies at an AUA meeting, and they were all doing prepackaged rescue instills, and they were under $100. You're just gonna have to call around. Ellen says, I went to order Bladder Builder, but it was out of stock. No, honey, we did get 69 bottles on Thursday. It should be back in stock. And then we're expecting another 1,500 bottles this week. They were mailed out to us on Friday. So you ordered Sister Renew. Is this pretty similar? Not at all. Not at all. Not even close. Not even close. I bet it'll be an interesting experiment for you to see if you like the Sister Renew, but the Bladder Builder is a very different formula that has PEA in it for pain relief. Lisa here on YouTube says, Cystex does nothing for me. Cecilia on YouTube says, my urgency frequency happens when I can't sleep. Does this have something to do with central nervous system? Yeah, certainly. I mean, if you can't sleep because of anxiety, if you can't sleep because you're stressed, well, anxiety is going to intensify some of these symptoms. Deb says, what is the correct way to fix a prolapse? Boy, hun, now there's a challenging topic. It depends on the type of prolapse you have and the severity of the prolapse, hun. There's no easy answer for that. Your surgeon is concerned that the prolapse surgery will harm your bladder. You should show him the case study that we have on our website of the woman who was healed by prolapse repair. I mean, does he think he's going to injure your bladder during the surgery? Or does he think, when you have a prolapse, Your bladder can drop down or fold over. Your uterus can drop down or fold over. Oh, here we go. Lisa. Okay, so Ellen. Or no, who is it? Not Ellen. It was Lisa. Lisa on Facebook. Lisa on YouTube has the answer for you. She gets her pre-made rescue installations from the professional pharmacy in Pennsylvania. It's a compounded pharmacy. Or no, she gets her ingredients there. Oops, sorry, I might have misinterpreted that. I know I'll recognize the names of the pharmacy when I hear them, but I just don't remember them. Vicky says, I'm going to an allergy doctor this week to figure out which foods I'm allergic to. I've had the shots they give you make the flares much worse. I seem to react to food and water, struggling with IC for 3 years, trying to go all natural. And you've been trying to go all natural with this natural supplements and diet, and it isn't working. I'm up to 10 to 15 times at night, urgency and pain that's gone in the morning. So again, Vicky, we have to think about cause and effect. So your nighttime frequency is the effect. We have to try to understand the underlying anatomy. And the very first thing we have to think about is estrogen atrophy. If your skin is dry, if your vulva's dry, your urethra's dry, and your bladder's dry, your bladder wall's just going to not be in good shape, and food's going to penetrate into the bladder wall and give you an issue. So you can modify your diet all you want, but as long as that bladder wall is very thin, it's going to be vulnerable and susceptible to irritation. But I would also, I would, yeah, you gotta understand the difference between an allergy and a sensitivity. And a true allergen provokes an allergenic response, like your throat swelling shut, you having difficulty breathing, right? Whereas a food sensitivity is different. A food sensitivity means that your body doesn't know how to process that food. It triggers an inflammatory response. So I don't have food allergies. I have food sensitivities. I'm extremely sensitive to chocolate. I'm extremely sensitive to oatmeal. They both trigger terrible flares for me, but I'm not allergic to them. I can breathe. My throat doesn't swell shut. So you're going to have to kind of learn about the concept of food sensitivities. Also, you can have food sensitivity testing. It's called ALCAT, ALCAT, ALCAT. You can order food sensitivity tests. They're blood tests. They're a little expensive. The more things you test it with, the more expensive the test is going to be. But Google ALCAT, ALCAT, and you can learn more about that there. Princess Pia, you like that? John, thank you so much for the 530 stars. Hello, Caroline from England. Cindy said, funny thing is, after I got a new puppy and I'm running around all day, my bladder works. Go figure. But Cindy, you're happy. Who couldn't be happy and laughing and joyful with a new puppy? And so your body is completely relaxed. Your pelvic floor is relaxed. Your central nervous system is relaxed. You're not going to be anxious. Your fight or flight's going to be turned off. Makes total sense. Hi, Kim. Tracy, random question. Do Bladder Smart and Bladder Builder work okay together? Sure. Because the Bladder Smart is a simple low acid vitamin, and the Bladder Builder is the more rigorous supplement that might help some of your bladder symptoms. So yeah, there's no conflict between them. Julie said, he said I would be cured. Interesting. Kathleen said, yes, I have been having recurring UTIs for over 4 months, continuing antibiotic after antibiotic. You're so sick of it. Not only getting instills at urology, but under the care of infectious disease. I'm 71 years old, and sadly in 2018 began to retain urine. Ooh, you have to self-catheterize 4 times per day. There you go. Anytime you're self-catheterizing, you're at much greater risk of UTI. He started you on methenamine several days ago, requiring vitamin C in order to work. This treatment goes against all I have followed for the IC diagnosis. Today I had excruciating abdominal pain, several bowel movements, feeling nauseated and depressed. I applied topical estrogen. Next month I will have another cysto, hydro, and bladder biopsy to rule out other stuff. I have great insurance. However, I'm only surviving on Social Security. I may not be able to afford it next year. and your urodynamics test showed a weak bladder. So the challenge here is you do have urine retention, right? And so that means urine sitting in your bladder for longer periods of time, that increasing the odds of exposure to pathogens. And then anytime you're self-catheterizing, you're also really potentially introducing bacteria. You should never, ever, 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 ever reuse a catheter. Hopefully they're giving you one-time use catheters. You got to really practice your sterile technique. I mean, wash your hands, wear gloves. You got to know exactly how you're using it. Uh-oh, hold on. Did something happen with Facebook? Yep, Facebook shut down. Did Facebook shut down? Yep, it says I'm offline on Facebook. All right, shoot. All right, so hold on. Let me restart Facebook. Oh wait, no, it looks like it's working. Hold on. No, it says it's working even though I got an error. You guys, Facebook is just annoying. But my video screen is not moving. And you can see every freaking wrinkle in my face. Oh my God, I'm getting old. So let me do this. Hold on. I'm going to end that video and I'm going to restart it. Hold on a sec. Yeah, I can see there was a bip in the stream. All right, hold on one sec, guys. Oh, the internet went out. That internet, AT&T, went down. That was the router under my desk because my Comcast router is over there and that's fine. But this router is that router is turning itself on right now. All right, so let's see if we can. Hold on. What the hell is that? I'm feeling a little salty today. Anybody else feeling a little salty? A privacy error? Oh, the joys of Facebook. Not. Hold on. Sorry, guys. Give me a moment. Okay, webcam, live, IC, and pelvic pain meeting, part 2. Let's try this again. AT&T crashed, stopping our meeting, but it looks like it's up again. So please join me if you have questions about IC. All right, hold on, guys. Thank you for your patience. Hold on. All right, FaceTime. No, the camera we want is my Pro Cam. A microphone we want is that microphone. We're not going to screen share. Let us go live. Going live in 3, 2, 1. All right. All righty. All right. Facebook stream is up again. We'll see. We'll see if it lasts. All right. All right. So for those of you on Facebook who are rejoining the AT&T shutdown, it wasn't your fault. It wasn't my fault. It was the internet service. So let me get this back. All right. All right. So Lisa says prolapse surgery didn't fix her. Honey, I'm sorry. You had everything in the pelvic area that fixed. Your cystoscopy, rectocele, bladder, uterus, bowel did not help the IC. So it didn't help the pain. What, Lisa, do me a favor. Don't use the word IC. Tell me what it didn't help. Did it not help the pain? Did it not, tell me, did it not help the frequency? Try to be a little bit more specific, okay? Kel says, for those of us who cannot take estradiol, what are my thoughts on calcium D-glucarate? I don't have any thoughts on that. Hello, Facebook. Hey guys, your internet, my internet shut down. AT&T shut you down. Don't ask me why. I have no idea why, but we're back. And I saved my questions. I was able to save questions. Oh, okay. Oh, there you go. All right. So for those of you on Facebook, I have now lost that last group of questions. So please feel free to ask them again. Sorry about that. Internet glitches. All right. So Lisa says that you still have pain and tight muscles in the bladder with lots of burning. Did the quality of the pain change at all, Lisa? Did anything change? Was the pain worse? Was the pain better? Is the pain in a new location? You have an axonics implant too. Okay. But I want you to think about post-surgical when you had all of that repaired. How did things change, if they did change? Hi, Sherry. Nice to see you, hun. We just had an internet outage on our Facebook stream, but we just restored it. And let me just look up. It's better than when you were first diagnosed. So which made it better? Did the axonics implant make it better? Or did the surgery make it better? And I'm still looking up calcium D-glucarate. Hold on a sec. Let me look that up too. I'll go to my top secret sources. Not. Calcium D-glucarate. Huh? Okay. Oh, interesting. That's very interesting. Calcium D-glucarate might lower estrogen levels, and this is thought to be helpful in treating some people with hormone-dependent cancers. It can reduce the excretion of toxins and some steroid hormones, including estrogen. Kel, I wish I had more info for you. There's one book I would look at. Hold on. Hold on. Let me see if it's in here. Hold on. Nope. It is not in there. Sorry, Kel. I wish I had more to tell. I don't. I just don't have any experience with that at all. Lisa said, getting back to Lisa, Lisa had a total repair of her rectocele, cystocele, prolapse uterus, bowel, bladder, etc. She said everything helps a little bit, but not enough. I'm still very happy with my doctors. They always think of something new. What's the health of your pelvic floor now, hon? Is your pelvic floor still really tight? And is it tight in a new location or the same location? Oh, see, look, you're having insane hot flashes too. Yikes. Hopefully you've gotten The Menopause Manifesto by Jen Gunter. That was the book that I just looked up. So this is when we would normally around 2 o'clock go into a Zoom and do a Zoom meeting. Does anybody have any interest in doing a Zoom meeting where you can tell your story yourself? If anybody watching has interest in doing a Zoom meeting, just put it in your chat and we could potentially open it up. So Lisa says, yes, it's tight in the same location, but less tight. I used to jump off the table. So good things are happening at least. Well, honey, it's the totality here. This is where Dr. Weiss, and again, I think this would be a very important book for you to have. Dr. Weiss talks about the totality of all the influences in the pelvic, and that for patients with interstitial cystitis and pelvic pain, Western medicine really fails because urologists like to play in their sandbox, the urinary tract. Gynecologists like to play in their sandbox, the reproductive tract. Gastroenterologists like to play in the bowel, and they don't necessarily look at influences. And it's really how the structures influence each other that is driving a lot of pelvic pain. So, muscle dysfunction, nerve dysfunction have the potential of influencing all of those organs. And how that happens and when that happens is important. That I call it the chicken versus the egg dilemma, but it's really more than that. It's the organ, it's the bladder, the pelvic floor, and the nerve connection. You got all three that are connected together. And our goal here now is to try to understand what is influencing each other. If you've got chronic overlapping pain conditions, IC, IBS, vulvodynia, irritable bowel, et cetera, then we know that you're being driven by your central nervous system, that your central nervous system is stuck in fight or flight and is hypersensitive. And that's what's driving all of the sensitivity in your skin, food sensitivity, drug sensitivity, wicked sense of smell. That's all central nervous system, right? Whereas if you have a bad hip, your symptoms all began after a fall or being hit by a car or being raped, then we know that it's muscle dysfunction that's driving everything. Whereas if your IC symptoms began because you spent 25 years drinking diet soda or massive amounts of coffee or you've gone through chemotherapy, we know that those chemicals have the potential of be damaging your bladder. Because your bladder's screaming in pain from the chemicals, your muscles are going to get tight to protect you, and then the nerves get involved, and oh my God. Okay, so Lisa here said she had three children that the childbirth ripped you apart inside. Yikes! So you also have some scar tissue that you've got to deal with. Hi, Loretta. Loretta says, I'm postmenopausal with estrogen-driven breast cancer. My gyne is uncertain about continuing any estrogen. Any thoughts? Loretta, if you could Google topical estrogen safety, you look at those studies. The studies are solid. The topical estrogen is considered pretty safe because it doesn't penetrate deeply into the body and into the blood vessels. I was at, well, God, what meeting was this at? Okay. Sometime last year, I was in a medical conference Zoom, and they were talking about estrogen exposure. And one of the speakers said that if you have a cancer risk, to not put the estrogen deep into your vagina, just to use it on the surface on the skin. And I can't tell you who that was. It was not at the International Pelvic Pain Society. It was like 6 months ago. And that was the first time I heard somebody actually say that. They said that using it on the outer skin, like at the entrance to the vagina and on your vulva, was allowed for even less absorption when compared to using it deep in your vagina. So talk to your doctor about that, okay? Elizabeth said, I had a hydrodistension done in the hospital back in the old days, 2011, after suffering with IC for roughly 3 years. My urologist described it as extending the bladder to 3 times its full size, and no one knows why. I feel like I have neurogenic bladder. It's like the connection between my brain and bladder is broken. I have bladder spasms. I had IC for years. I had no problem starting a urine stream until this procedure. Feel that my bladder will never be normal. So in 2011, Elizabeth, the American Urology Association issued new guidelines for interstitial cystitis where they specifically address that, where they are telling doctors, or they told doctors, do not overstretch the bladder. Do not do high pressure, long duration procedures because of the risk that presents of bladder rupture and damage. They recommended low pressure, short duration procedures because it minimized the damage. So it legit sounds like he damaged your bladder he extended your bladder to 3 times its full size. Have you seen another doctor? Have you gotten a second opinion on that? I really would want you to get a second opinion on that. What state do you live in, hon? I might be able to suggest somebody. That sounds there is a very small population of patients, or a small proportion of patients, who say that they believe that hydrodistension damaged them. It's yeah, back then, yeah, they were damaging. The AUA acknowledges that they were damaging. The AUA acknowledges that many patients refuse to go back to their urologist after having been hurt by procedures like that. But now we have to try to understand what happened. And boy, I would really love for you to see somebody like Robert Evans or Ken Peters. Ken Peters right now is in Africa for a month doing surgery. But Robert Evans, Rob Moldwin, somebody like that, I would really want somebody to try to help understand what happened to your bladder. Do you have any medical notes? So if you're having bladder spasms, does an antispasmodic work like ditropan or Detrol? The bladder is composed of smooth muscle, so you need smooth muscle relaxants. So the absolutely classic antispasmodics are going to be ditropan or Detrol, also known as oxybutynin or tolterodine. Have you tried any of those? Debbie says, totally agree that all of our systems are related. I know if I get constipated, my IC pain increases. I've had IC pain for 20 years. It's all a matter of finding how your body responds. Yeah, it's weird, and our bodies change as we get older too, and that makes it all the more challenging. Like my IBS it has been silent for 15 years now. I because I know the foods I'm not supposed to eat, and I don't eat them. But I do know that if I were to have an IBS attack that involves diarrhea, then your muscles really get tight because of that. So many times I wouldn't be able to urinate for 5 or 10 or 15 or 20 minutes after being in the bathroom with an IBS attack, because you have to wait for those muscles to relax a little bit. Okay, my SI joint is not happy. Hold on. Oh, dear God. I get two different pains. Like I don't know if you can see this. I get a sharp pain like right. Okay, hold on. So my SI joint's like right here. And when I sit too long, I get this little throbbing pain like right here. Where's my thumper? Here, hold on. I'll be right back. Hold on. I have this really good. Where is it? Oh, here it is. Oh my God, it was right there. So I got one of these. It's a Theragun, right? And so I find that, and I talked to my doctor about it. I talked to my doctor about it to see what I could and could not do. And basically, when that starts to happen, I go right here. Like it's right around the tip. Yeah, it's like right there. Oh, there it is. Woo, right there. This has like been one of the best things, especially with COVID, when we have not been able to get. Oh, ow. Ooh. That's like how my body has changed as I've gotten older. It's like it's just harder to sit. You know, like I can sit for. We've been doing this for almost 2 hours, and it just started like 2 minutes ago. And I get this thumper in there, and it's like almost as good as having a massage. Ooh, God. I mean, like, see, so is the pain gone? Yeah, see, now the pain's gone. Okay. Not that you needed to see a picture of me thumping my butt. I'm sorry. You know, guys, I mean, listen, 25 years of doing this. In the old days, I was extremely academic. It would never have said but, it would have said gluteal muscles. Are you urinating or defecating? We're so over that. It's like it's all. So I'm just very direct. I'm sorry. My tush. CMB says, I've been seeing Dr. Evans for almost 15 years. My IC is under control most of the time. He's truly amazing. He is. Julie wants to know a good doctor in Northeast Ohio. I think I have my database of doctors open. Let me look. I do. Oh, hold on. Okay. Ohio, the great state of Ohio. Dan Chosky's at the Cleveland Clinic has retired. I need to take him off of our list. We have somebody in Cincinnati, Cleveland, Columbus, Twinsburg, and Salem. Are any of those close, hun? If any of those are close, I can give you Robert Evans is located at Wake Forest University in North Carolina, Greensboro, North Carolina. Debbie says, my distensions were terrible. Never again. I know the foods I eat hurt, but I love so many of them. You know, guys, Karen, are tomatoes really bad for IC? Tomatoes are really bad for a wound. And it's about the quantity of acid, Karen. So think about it for a moment. There are like a dozen tomatoes concentrated into 1 cup of tomato sauce, right? They've all been they've been cooked down, but that's the acid of like a dozen tomatoes. That's a lot of acid. If you got a sensitive bladder wall or you got a wound in your bladder, the last thing you want to do is bathe that wound in acid. So tomato sauce is really rough. Tomato paste worse. However, you might be able to tolerate the slice of 1 tomato on a sandwich because there's so much less acid in that little tiny piece of tomato as compared to a cup of tomato sauce. So yes, tomato sauce in particular is bad if you have Hunner's lesions, IC subtype 1 or bladder wall driven IC subtype 2. They're or estrogen atrophy. It's going to be an issue. Now, Debbie brings up something important. Deborah brings up something very, very important here from Facebook because we are simulcasting on Facebook and YouTube. So I'm looking at both of you. Here's the deal. Having a bladder injury and or pelvic pain, especially severe pelvic pain, like begging God, please help me, is a wake-up call. It is a reckoning. It is about you understanding that some of the things that you might have fallen in love with, whether it be coffee, whether it be chocolate, whether it be diet soda, are damaging. They are damaging over time. You know, you have to remember that your bladder was designed tens of thousands of years ago. Evolution, it takes 5,000 years for an evolutionary adaptation to occur. Okay. So the bladder you and I have is the bladder from 5,000 years ago, where there was not massive amounts of coffee or soda or diet soda or chemicals. And the bladder is not, made of metal. The bladder is real human tissue. And if you bathe that tissue in acid over time, if I were to pour, so let's just say a very mild solution of sulfuric acid on my hand every day for a month, what do you think would happen? Well, slowly that area would start to turn pink. Then it would turn red. And if I was foolish enough to continue it, then we would start seeing wounds. And now that we have an open wound on that skin and I'm pouring sulfuric acid on that wound is now going to get bigger and bigger and bigger and bigger. As long as you are pouring acid on the wound will never heal. And in the bladder in particular, you have to understand about the bladder is it is the slowest healing organ in the human body. Why? Because it has the largest single cells in the human body. So if you were to look at an electron microscope at the bladder wall, it's like a beehive, big giant hexagon cells. And these cells have what we call tight junction. This is a structure that keeps urine contained. Okay. But it can still be damaged. So imagine an extra large pizza and a little tiny green pea underneath that pizza. So the extra large pizza is the umbrella cell. Okay. It is the urothelial cell. I want you to imagine now that it is damaged. It is gone. Because once the cell is damaged, the body sloughs it off. It doesn't stay there. It normally gets sloughed off. All right. So underneath that extra large pizza is one single little pea called a stem cell. And it takes 2 weeks for that stem cell to grow and grow and grow and grow and get bigger and bigger and bigger and bigger until it's now the shape of the pizza. But while that stem cell is growing, it is exquisitely vulnerable to acid. And this again was at a National Institutes Health meeting on IC, and I do believe the speaker was Dr. Anthony Schaefer talking about how the bladder repairs itself. And what he said is that that stem cell, while it's growing and trying to repair that wound, is exquisitely vulnerable to acid. That literally one cup of coffee will kill it. One cup of coffee will kill the next generation of cells trying to repair your bladder wall. And, I remember I was sitting there with the other IC patient organizations, specifically the ones from Europe that I was pretty good friends with back then. We were all looking at each other going, that's why patients who drink one cup of coffee a day are the worst, because they never, ever, ever have allowed their tissue to repair itself. That the bladder damage is continuing. It is continuous. So your job is to create an environment that supports bladder tissue repair. If you're IC subtype 1, IC subtype 2, Hunter's lesions, bladder wall driven, estrogen atrophy, chemocystitis, your number one job is to create an environment that will support healing. And if you had a wound on your hand, would you pour coffee on it? No. Would you pour soda on it? No. Would you pour cranberry juice on it? No, absolutely not. You have got to let all of that go for like 3 to 6 months so that the tissues have a chance to heal. Because if you don't, and that's why I always say, please don't think of IC as a disease. Because when you think of it as an IC disease in your brain, you're going, oh, I'm not going to let this disease rob me of something I like. I'm not going to let this disease rob me of coffee. I love my coffee. But if you think of it like an injury, you go, oh, wait a second. What would happen if I poured coffee on an open wound in my bladder? Oh, that's not good. That's not good at all. That's why diet matters. That's why diet matters. And the top foods that you want to avoid are going to be the foods that are going to be high in acid, high in caffeine, high in alcohol. So this is going to be no coffee, even decaf, no green tea, no black tea, no soda, no diet soda, no fruit juice, no cranberry juice, no lemonade, etc. Chocolate is allergenic. It's neurostimulatory, so it's really no chocolate either, and it's certainly no caffeine. Caffeine is like taking a jackhammer to the nerves. If you're an IC subtype 4, IC subtype 5, which are all based on nerves, the last thing you want to do is take a jackhammer to those nerves and increase your neuroinflammation. Your job is to create an environment that will support your bladder and your pelvis healing. So you got to let it go. I didn't drink coffee for 10 years. Easy. I haven't eaten chocolate willfully for 25 years. And I'm better. And my bladder is healed. My IBS is completely controlled. But when I jump down the coffee pathway, which I do, like every 5 years or so, I'll start drinking it again. And it doesn't hurt me immediately. But what happens is that slowly but steadily, my nerves start getting irritated, more and more and more irritated. That's exactly what I say to the doctor. And then eventually, 6 months in, I end up in the emergency room like I did last year and getting another lecture on stop the freaking coffee. You're a redhead. You're too sensitive. You can't do the coffee. So, there comes a point in time where there's a reckoning with bad habits. There's a reckoning with bad food choices. It makes no sense for you to be pouring acid on the wound. And it makes me think of a patient that I worked with in New York who I will always remember her voice. She just had a very, very, very distinctive voice. And she called me with frequency, urgency, IC. I spent a lot of time with her, went through the diet, went through everything. I mean, this was like 15 years ago. And then she happened to be very close to Rob Moldwin, one of the best doctors in the country, sent her there. It was done, right? 5 years later, she calls back and she's hysterical in pain. Jill, nothing's working. I can't sleep. I've got this terrible frequency urgency. I don't know what to do. Right. And I mean, she's really upset on the phone. And so we're like, okay, talk to me about it. What are your symptoms? And she had pain as her bladder filled with the urine that was relieved by urination. So the fuller she got, the worse she felt. But as soon as she peed, she felt better. So I'm like, okay, that really sounds like a bladder wall flare, hun. So are you following the diet? She goes, yes. Well, her husband was on the phone. He goes, are you kidding? She doesn't follow the diet. She drinks a pot of coffee in the morning and a 6-pack of diet soda in the afternoon. I mean, he let her have it. He threw her under the bus in the best possible way. And she started wailing on the phone, wailing. That's right. Take away everything I love. I will have no reason to live if I can't have my coffee and I can't have my soda. I mean, she was wailing like she was at a funeral. And I'm listening to her and I go, honey, how much money have you spent on therapies? She goes, about $20,000. And I said, do you realize you've sabotaged every single therapy? She goes, what? I went, nothing could work. Nothing would have worked for you with you pouring acid every hour into your bladder wall. There's no therapy out there that can counteract that damage. You have sabotaged every treatment you have done. And she's like, what? And I say, now, wait a second. I know I talked to you about the diet. Didn't you believe me? She goes, no. I said, you went and saw Rob Moldwin. Didn't he tell you about the diet? Because his clinic did the diet research. He goes, yeah. And I go, didn't you believe him? She goes, no, didn't believe him. Every single doctor you saw told you about the diet, right? She goes, yeah. I said, you didn't believe any of them? She goes, no, it didn't apply to me. And I went, oh, it applied to you, hon. You're an addict. You're an addict. You're addicted. You're totally addicted to caffeine and you're totally addicted to sugar. That's what an addict does. That's what an addict does. And she got very, very quiet on the phone. And then I explained the whole pepperoni pizza thing. I said, your bladder simply cannot heal. All you're doing is perpetuating the damage and making the damage worse with what you were doing. If you want to get better, you got to lose the coffee, you got to lose the diet, you got to lose all the soda. Please, God, believe me. Everybody told you about the diet. You have to believe us. Well, she was very quiet and humble afterward and went, oh, okay, right? And she's still kind of misty and crying. And her husband was like, thank you. I've been telling her this for years. She calls me back 3 months later. She goes, Jill. I'm like, what? I'm going, oh my God, what? I'm better. I never thought it would happen. And I said, well, what'd you do? She goes, I finally stopped the coffee and the soda. And I went, congratulations, son. You've allowed your bladder an opportunity to heal. And she's healing. She saw cause and effect. You have to understand cause and effect here. So again, don't think about this as this weird disease, because we don't think about this as a weird disease, except maybe Hunter's lesions. That's Hunter's lesion disease. But for the rest of us, it's a pelvic pain syndrome. And it's usually about injury or trauma to the bladder, to the muscles, to the nerves. And your job is to create an environment that will support tissue repair. So you got to let it go. But this is hard if you're an addict. And you got to find that strength. If you want to get better, you can't pour acid on the wound. It's just that simple. WSM, looking for a doctor in Orlando, specializes in IC or Hunters. Let me look at my list. Okay, and hold on. Julie said she was looking for somebody in Cleveland. So Julie, in Cleveland, you're going to be at the Cleveland Clinic. Dan Shoskis was there. He's retired now, but his office was pretty familiar with interstitial cystitis since he's done a lot of research. So Cleveland Clinic would be my suggestion for you. Dr. Andrew Altman, although it looks like he works more with men than women, but check out the Cleveland Clinic, okay? Okay, and then somebody said Orlando. Hold on, let me go to Florida here. In Orlando. Hold on. Um, Coral Springs, West Palm Beach, Miami Beach, Aventura, Naples, or Winter Garden. Are any of those close to you, hon? And then you can check the database on our website too. We have our own database. This is a special pelvic pain database that Dr. Day gave to me from Harvard last spring. I should get an update for it too. Yeah, and Facebook crashed. AT&T crashed actually. Can I use coconut oil instead of estrogen? I'm quitting estrogen. No. Well, I mean, again, cause and effect, hon. Cause and effect. All the coconut oil is going to do is quench that skin. It's not going to fix that skin. Estrogen has the potential of fixing that skin because you're giving the skin what it needs to produce mucus. So you can't compare the two. You cannot compare it. The most important for people with estrogen atrophy is using that little bit of topical estrogen because your skin can produce that mucus. Oh, WSM, yeah, Winter Garden. All right, hold on. Let me tell you. It's Avant Concierge. Yeah, this is perfect for you. Avant Concierge Urology, and it's Dr. Parakatil. So Avant, AVANT, Concierge Urology. Also wrote 2 chapters in the book Facing Pelvic Pain that I shared earlier. I'm also one of the authors in this book. So Dr. Parekattil. So again, Anne, you can't compare the estrogen with the coconut at all. The estrogen gives your skin what it needs to produce mucus. The coconut oil is just passive. And you got to have a reality check here. It's all about the quality and health of your skin here. Don't think that the estrogen is going to make your IC symptoms go away. It's improving the health of the skin. That's all. It's part of the package here. Amy says, I don't drink coffee, never have. I also stopped drinking any soda for 8 years and it didn't help my IC at all. In fact, it was actually worse the last 5 years. I urinate straight acid most of the time. Okay, so Amy, again, cause and effect. If you stopping drinking soda didn't help at all, then has somebody looked in your bladder, and what does a bladder look like? I'm going to bet that your bladder looks normal, like mine. I mean, I know I remember subtypes. We have subtypes. We have different variations of IC. Hunter's lesions is IC subtype 1. Technically, it's bladder pain syndrome subtype 2 is focusing on the bladder wall itself. So we can have chemical cystitis, we can have estrogen atrophy, we can have chronic infection in that subtype. Our third subtype is pelvic floor driven. That's our biggest subtype. Our fourth subtype is pudendal neuralgia. That means that a nerve is injured, the pudendal nerve. And then our fifth subtype is chronic overlapping pain conditions, where these are patients who have IC, IBS, vulvodynia, lots of different pain conditions. So we have to try to understand the underlying anatomy as to why it feels like you're urinating straight acid. If your symptoms began after menopause, then we know what we're dealing with, estrogen atrophy. And that's not a disease process, that's the loss of estrogen. Your skin can't defend itself. It's called the genitourinary syndrome of menopause. You know, your skin is like your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. And the purpose of that mucus is to protect the tissue. We call it the mighty mucus. So you have this nice thick coating of mucus that keeps urine off of the cells of your bladder wall and prevents bacteria from infecting your bladder wall. Unfortunately, that mucosal barrier, the gag layer, is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus and you can get away with stuff. But when you're older, guess what? You don't have the estrogen. Therefore, you don't have the mucus. Thus, your bladder's ability to defend itself is now compromised. And so, foods that you might have been able to eat in your 40s, all of a sudden you can't eat in your 50s. You think you have a UTI, but you don't have a UTI. It's estrogen atrophy. And the urethra is kind of the first part of the urinary tract that signals when your estrogen levels get really, really dry. So okay, they do a scope. Okay, hold on a sec. They do a scope and hydrodistension every 6 months. They said I have a small bladder and it is getting smaller. I also have urethral stenosis. Okay. So, any top tier doctor at their very first meeting with you would immediately do two things aside from taking your history. They would assess your pelvic floor muscles and they would look at your skin. So, what's going on with your pelvic floor, Amy? Are your muscles tight? Because I'll tell you what, tight muscles burn. Tight muscles cause a burning sensation. It will feel hot. So what's going on with your muscles and what's going on with your skin? How old are you? If your vulva's dry and your vagina's dry, so is your bladder. Wanting One Angel says, I never injured my bladder, but I have IC. I know somebody whose bladder was punctured due to horseback riding injury and she does not have interstitial cystitis. Well, honey, it's a syndrome. It's a syndrome. There are lots of things that can injure the bladder. You could have a fibroid tumor pushing on your bladder. You could have endometriosis attached to your bladder. You could have extremely tight pelvic floor muscles that are restricting blood flow to the bladder, and the bladder wall breaks down because of poor blood supply. You could have neuroinflammation. All right, so here, hold on a sec. So Amy says you were diagnosed with IC when you're 23, and you had to have a hysterectomy when you were 25. You do have pelvic floor dysfunction as well as lichen sclerosis. Honey, how old are you? How old are you? And this is my question for you. Go back in time. So how many years has it been since you were diagnosed? Go back in time to the months prior to the onset of your IC symptoms. Did anything happen? A car accident, fall, a rape, period of very high stress? Was there some sort of trauma that happened in the months prior to that? Were you an athlete? Were you a dancer? Ice skaters who take a lot I was working with an ice skater actually on Friday, who had really severe pelvic floor dysfunction. She just didn't understand why. And I was like, well, what did you do? She goes, oh, and I was an ice skater. I went, well, there it was. How many times did you fall on your tailbone? She goes, many times. Well, this would explain it why your muscles are tight that eventually involved your bladder. So you did, Amy says she did physical therapy for a PE. What do you mean by PE? Shari says, New Jersey urogynecology practice I know of. Okay, thank you for those. Guys, if anybody has a really good doctor that they like to recommend to others, would you please email me their name and contact information? icnetwork@mac.com. IC Network. Okay, so you did physical therapy for pelvic floor. Me too. Okay, you're 51 now. Okay. So just understand that muscles will go back into tension. And so pelvic floor therapy tends to be, stop for a couple years and you have to go back to it. At least I've had to because I'm 61 now. I've gone through 3 courses of physical therapy for my pelvic floor, and I'm in a new course right now. But go back in time, Amy, to the time when you were 23 and your symptoms started. Can you remember any trauma, any fall, anything? Debbie says, wait, could the severe endometriosis I had affect me after my hysterectomy? My urologist poo-pooed the idea. Absolutely. Absolutely. Endometriosis can attach to your bladder wall. It can burrow into your bladder wall. And the thing is that, yeah, you've had a hysterectomy, but it's very hard for them to get all of the endo. There can be microscopic cells of endo that get left behind that can still cause problems. Okay. So Amy, do you have super sensitive skin? Susan says, my physio said it's a limbic system disorder. It's IC subtype 5 chronic overlapping pain conditions is indeed a fight or flight. You're absolutely right. Absolutely right. That our brain, specifically the amygdala, is stuck in fight or flight for patients with chronic overlapping pain conditions. This is new research that we've had in the last couple of years, which is why bladder therapies wouldn't necessarily work with somebody who has IC-IBS vulvodynia because it doesn't address the underlying dysfunction. Um, let's talk about this for a moment. Here, hold on. Let me get a drink. So last year, I attended the International Pelvic Pain Society meeting, and it blew my mind. Wait, hold on. Well, let's go back to Amy here for a moment. Amy says, I did have severe endometriosis. I had half of a uterus and one fallopian tube, I guess, removed. I don't remember having a fall or anything like that. I did have a good stretch of time where I didn't have many problems, probably 5 to 8 years. And now it's back with a vengeance and horrible. Okay, so the fact is that you had endometriosis, and now you have IC, and you have lichen sclerosis, which is also it's neuroinflammatory. So let's go into this a little bit here. So, about 10 years ago, the Chronic Pain Research Alliance was born. So these are the independent patient groups. One group who worked with TMJ, the other group worked with vulvodynia, another group that worked with IBS, et cetera, et cetera. They all got together and formed a research team called the Chronic Pain Research Alliance. And their goal was to try to figure out why some, but not all people develop multiple pain conditions. I mean, this is my subtype 2. Absolutely, it's my subtype 2. So, they started fairly early doing brain scans because ultimately we have to look at connections in these people. So they started very early doing a lot of brain scans. And so did our own National Institutes of Health MAP Research Network, which is the IC pelvic pain NIH funded research team. They also started doing brain scans of IC patients. And I didn't talk about it a lot because number one, I didn't understand it. Number two, I actually thought it was a little bit scary. And so I really didn't talk about it a lot in our magazine or in these life support streams. But I will say now, after attending this meeting a year ago, I completely understand it. And there's absolutely a happy ending at the end. So even though I'm talking about the brain, don't get scared. We get it. We really understand it. We have a much better understanding of why this happens. So here's what those brain scans found. Those brain scans found that patients with chronic overlapping pain conditions, their brain, specifically their amygdala, the portion of the brain that controls fight or flight, is stuck on. That these patients' brain, 24 hours a day, thinks their life is at stake. They are in extreme fight or flight. And interestingly, Amy, the case study they used was a woman who, number one, in her teens, had very painful periods, then in her 20s was diagnosed with endometriosis, then was eventually diagnosed with interstitial cystitis and irritable bowel, etc. They used that case. That's classic case study. Okay, so again, somebody with chronic overlapping pain conditions, their brain is stuck in fight or flight. So let's talk about that for a moment. You have to understand that this is a very primitive part of the brain. There's no cognition happening here. This is your brain paying attention to your senses. What do you see? What do you hear? What do you taste? What do you smell? What are you touching? Is it hot or cold? Will it burn you or pleasure you, for lack of a better term. So if you were to open your front door and you opened it and you saw a saber-toothed tiger across the street, you would immediately go into fight or flight. Like, that's a threat. So the sympathetic nervous system takes control, and the amygdala in the brain coordinates the sympathetic. I mean, that's the coordinator for fight or flight. That's how we know fight or flight is on, is the amygdala is firing. So, of course, while the saber-toothed tiger is there, your brain is going, threat, threat, threat. You can die, you can die, you can die. It raises your blood pressure, it raises your heart rate, it tightens your muscles, and it prepares you to fight the saber-toothed tiger. But the saber-toothed tiger walks away, and you watch it, and it's a mile away, and now it's way far away. It's not a threat anymore. Normally, at that point in time, the parasympathetic nervous system takes over, calms the amygdala, reduces your heart rate, reduces your blood pressure, relaxes your muscles. Okay? Unfortunately, that isn't happening in somebody with chronic overlapping pain conditions. We are stuck in fight or flight, stuck there. Our brain thinks at any given moment of any given day, our life is at stake. One of the classic signs of somebody with this is chronic anxiety, catastrophic thinking, which also is a part of the fight or flight response. So at the conference, the most important course that I took, or class that I took, was the risk factors. Why does this happen to some people and not other people? And what the risk factors showed is that in 80% of the kids that this happened to, there was a physical trauma and pain. Okay. So, and unfortunately, children, when they're hurt, they're not very good at explaining they're in pain, and they often tend to be minimized and ignored. And so 14 to 15 days of pain turns on fight or flight, and you're stuck there. You get habituated in fight or flight, right? The brain has changed. 14 days of straight pain will change the brain. So 80% of the patients, physical trauma that was basically painful. But for the other 20%, it was a history of bullying or abuse. And that's the best example that I can give you. I want you to think about a child who has a bully at school, like a really, really bad bully at school who hurts them, who physically hurts them. So that child, when they wake up in the morning and mom wakes them up or dad wakes them up, honey, got to get dressed, got to go to school. That's when that child goes into fight or flight. And then the closer they get to school, the more hypervigilant they are. It's like, oh my God, where is he? Oh, there's his friend. I better be careful. Oh my God, where is he? And God forbid, recess. Recess is the worst, because that's when the bully can sneak up on you, right? So this poor young child, massively hypervigilant, in total fight or flight. The only rest that they get is when they walk in their door at the end of the day for 3 to 4 hours. They're good. Everything calms down. They're safe. And again, this is a very primitive response. This is not cognitive. This is primitive. But then mom says, hey, hon, got to go take a bath, got to go to school tomorrow. They go right back into fight or flight. What the research again shows is that 20 days of that habituates the brain to fight or flight. Nobody is saying that this is a mental illness. This is not a mental illness. This is called a central nervous system maladaptation, that the brain has become habituated into fight or flight. And here's the problem, is that when you're anxious and you're in pain, that intensifies fight or flight. Your brain, it will intensify that pain. It will make it much more severe, because that primitive response thinks that your life is at stake. Whereas pain that is accompanied by laughter is minimized by the brain, because you're laughing, therefore your life can't really be at stake, right? So 20 days of bullying, 20 days of abuse, if you have an abuser at home. I was working with a patient early last week who suffered terrible child abuse when she was younger. She absolutely was completely stuck in fight or flight. Now she's in her 50s. Her abuser is long dead, but she's never been able to get out of fight or flight. And she's got all the pain conditions. She's got the IC and the IBS and the vulvodynia and all this sort of stuff. And if the bully is at home, yeah, then you're in fight or flight at home. Well, Amy, they say it's a perfect storm, but it's more than that because the endometriosis created the foundation for this with the pain, right? This is the classic escalation of central nervous system driven sensitivity that's driving multiple pain conditions. So, but here's the good news. We know how to fix it. The key to therapy for these patients is we have to get your brain out of fight or flight. If we get your brain out of fight or flight, what do you think happens? Your muscle tension reduces, your blood pressure reduces, your heart rate reduces, and the nervous system as a whole calms down. Think about the toll that 20 years of fight or flight would do on the body because your muscles are tight. They're just being driven tighter and tighter and tighter by this long-term fight or flight. So think about this very primitive part of your brain for a moment. It's just sensory information. What do you see? Is it a saber-toothed tiger or is it a puppy? What do you hear? Is it somebody screaming or somebody laughing? What do you smell? Is it a fire or is it perfume? What do you taste? Is it poison or is it chocolate? What are you touching? Is it hot and burning you or is it safe? It's this, and like go back 50,000 years when, the fight or flight was helping them find good water versus bad water, good food versus bad food, right? It's sensory information. That's all your brain is using to determine if your life is at stake. You sensory information. So it inputs your sensory information and then it relates it to your history. Have you smelled this before? Have you heard this before? Are these the footsteps of your abuser? You will go right back into fight or flight. So how do we reverse that damage? Easy. We turn it off. And when you turn off the amygdala and you turn off fight or flight, what do you think happens? The pain, all the pain, and the entire central nervous system calms down. So we do that with good sensory information. We force the brain to become normal again. We give it good sensory information. That's called mind-body medicine. So let's do it. I want to show you the technique that I love the most. It'll take less than 5 minutes. And it will for everybody watching this who's stressed, you will feel better after we do this, okay? You will feel better. So let's just try it. We're going to do I Spy for a moment, okay? Let's just do I Spy. So I want you to pick something in your room. Pick something in your room and just look at it. It can be a painting on the wall, it can be a quilt, whatever. A plant, a puppy sleeping on your bed, a cat sleeping on your bed. Just pick something in your room. So I got a really beautiful cat over here, a porcelain cat. Okay, let's just look at it for a couple seconds. Let's take a nice slow deep breath in, deep breath out. Okay. What can you hear right now? Besides my voice, can you hear anything? Do you hear anybody laughing? Do you hear a TV on? Do you hear traffic? Do you hear the wind? Let's just take a moment and listen. What do you hear? So I can hear a TV in the distance. Okay. Nice slow deep breath in. Deep breath out. Okay. What can you smell right now? Can you smell anything right now? I can smell my Dandy Blend no acid herbal frappuccino. It smells good. So what can you smell right now? Just smell it. Okay, let's take a nice slow deep breath in. Deep breath out. What can you taste right now? Can you taste anything? Did you just eat a banana? Can you taste your lunch? Can you taste what you're drinking? Any flavors in your mouth? It's okay if there aren't. Just focus on that just a little bit. Okay, let's take a nice slow deep breath in. Deep breath out. Now I want you to take your hand and I want you to rub it on your pants or rub it on your skin. Rub it on your arm or your shirt. Just rub it. I'm rubbing it on my jeans. Now your brain, this very primitive part of your brain is going, okay, you're rubbing it. It's fine. There's no worry. But you see, we're forcing that brain to pay attention to that. That's good sensory information. Okay, let's take a nice slow deep breath in. Deep breath out. Okay, now comes the good part. If you could look at anything that would put a smile on your face, what would that be? If you could look at anything that would put an immediate smile on your face, what would that be? Would it be a grandchild, a daughter? Would it be a cat, a dog, a beloved, friend? Think about that for a moment. What would you love to look at that would immediately make you feel good? And for me, it would be, any cat or dog. So just live there for a moment. I can imagine my cat walking up my hallway. Okay? Let's take a nice slow deep breath in. Deep breath out. What could you hear that would immediately put a smile on your face? What could you hear? Would it be music? Would it be the laughter of children? Would it be a hawk calling from the sky? Would it be the voice of your mother, your grandmother? Close your eyes and just be there. Can you pretend that you hear them? You do hear them. For me, it's like any John Denver song or Kenny Loggins song. I listen to a lot of Kenny Loggins. All right. Deep breath in. Deep breath out. What could you smell that would immediately put a smile on your face? What could you smell? Would it be your mom's favorite perfume? Would it be hot apple cider, a hot apple pie, cinnamon roll? Pick your favorite smell. For me, coconut, anything coconut, okay? Close your eyes and just be there for a moment. Like, I can smell this wonderful coconut that I love so much. Okay, deep breath in, deep breath out. What could you taste that would put a smile on your face? What's your favorite thing in the world to eat or drink? What is it? For me, always hot cinnamon roll every single time. Close your eyes. It's right there. You remember it. You're tasting it. Oh my God, it's so good. I could have this every single day. Deep breath in. Deep breath out. What could you touch that would put a smile on your face? What could you touch that would put a smile on your face? Would it be petting a cat or a dog, your lover? Various body parts? Would it be a silk fabric? Would it be a new baby skin? What could you touch that would put a smile on your face? Now close your eyes and just pretend that you're touching it. Okay, deep breath in and a deep breath out. Now, how do you feel? You feel good, right? Like, you cannot not feel good. You've just spent 5 minutes imagining the best things that you can have. This is good sensory information. It immediately turns off the amygdala. Your amygdala is turned off. Your parasympathetic nervous system is now controlling your brain. It's calming everything down. And it will stay here for hours. It will be here for hours. But this one other burden that somebody with chronic overlapping pain conditions has, and that is anxiety disorder. And I've asked a lot of doctors because, listen, You can't kid a kidder. I had very severe anxiety disorder as a teenager, and then in my 20s, and even into my early 30s. Very severe. I mean, I had panic attacks going to the doctor. So here's the problem: is that the odds are you are living in anxiety with anxious thoughts all day, every day. And you're not just having one thought, you're like having an anxious thought every other minute. Hey, Jill, you want to go to a movie? Oh, no, not going to be able to get to the bathroom. Hey, Jill, you want to go take a drive? No, the drive's going to hurt. No, thank you. Hey, you want to make love? No, I don't want to risk it. Hey, you want to do anything? No. We're the no people. That's anxiety. That's catastrophic thinking. And every time you have that thought, you go right back into fight or flight. Because again, it's very, very primitive. So the second piece of this puzzle is we have to address the negative thinking and the anxiety. And again, I've asked a lot of doctors, why are our thoughts negative? And they're like, it's just chemically easier. You're in fight or flight. That's it. I mean, I'm a very optimistic person. My magazine is called The Optimist, and yet for 20 years I was on the inside. I hid it very well. I was Miss Negative, like, no, 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 don't talk to me about anything. No. Okay. So I finally had a panic attack, really bad panic attack, before going to a urologist. And I was just like, I'm done. I don't want to do this anymore. I hate living this way. Help me. And I signed up for a class at my local Kaiser called Phobies. And it completely changed my life because it was developed by a surgeon with anxiety disorder for his son who had anxiety disorder. And he explained anxiety disorder as a chemical overload, that there's way too much adrenaline floating through our bloodstream that is driving all of this. We're stuck in this miasma of fight or flight adrenaline, fight or flight adrenaline. And we're sensitive anyway. And we're not just sensitive to chemicals on the outside of our body, we're also sensitive to chemicals on the inside of our body, specifically adrenaline. And adrenaline is what drives fight or flight chemically. So he said what we've got to do to make you better, we have got to get you out of adrenaline overload, because right now you're having negative thoughts every other minute. You have a shot of adrenaline with every negative thought. You are in chemical hell right now. So they taught us a foolproof system to reduce the adrenaline level. And it changed my life. I do not have anxiety disorder anymore. I have not had a panic attack since I took this class. I was 35. I'm 61 now. Okay. I went through uterine cancer, not a single panic attack. I know what to do. So they taught us a very simple system. Stop sign, deep breath, minimize the thought. That when you have a negative thought, the first thing you do is just close your eyes and visualize a stop sign. Just stop it. Stop. Just stop in your brain for a moment. Then you take a nice, slow, deep breath in and out. And that oxygen turns off the adrenaline from that negative thought. Okay? Renders it chemically neutral. So stop sign, deep breath. And then the third step is you got to say something to yourself to remind you that it's a negative thought. It has no power. It just has no power. So what I say to myself is, oh my God, Jill, how arrogant can you be to think that you can predict the future? For all you know, tomorrow is going to be a blessed day. You're not God. Get over it. It's a thought, right? So that's what I say to myself. So stop sign, deep breath, minimize the thought. So they said, okay, we have one goal for this week. All we want to do is get you out of adrenaline overload. That's all we're going to do. So we want you to be really, really attentive. When you walk out of this room, we want you to start. Pay attention to your thoughts. Stop sign, deep breath, minimize the thought. And I'm a chemist. I got 2 degrees in chemistry. I was interested in the chemistry. So I'm like, all right, I'll give it a shot. I got nothing to lose. I'm ready to change. I was shocked. Like literally 30 seconds out of walking out of that room, I had my first negative thought. Like, it'll never work. But when you really pay attention to your negative thoughts, holy hell, are they harmful? Like, my negative thoughts were just, I was nobody would love me, that I was a waste of space, that I was damaged goods, that I was an embarrassment. God. And I was so used to it. It had been going on for so long. I just tried to ignore it, but I couldn't, because when I actually paid attention to it, it's like, holy hell, I was so bloody mean to myself. But anyway, I did it. Stop sign, deep breath, minimize thought. And the first day, I probably did it 100 times. I'm not lying. This is a true story. The next day, I was still doing it. Did it about 50 times. Day after that, did it about 20 times. A week later, I was doing it once a day. Once a day. And for the first time in 20 years, I was calm. I was at peace, because you know what? I was now out of the adrenaline overload. And what I learned is the secret to controlling anxiety is to not let it build. You can't, you got to stop it every single time. So, and it's been hard with COVID, because we've all been living in the hell of COVID. But as I listen now, and if I have a bad negative thought, it's exactly what I do. Stop sign, deep breath, minimize the thought, because I'm not going to let it build. I'm going to nip that sucker in the bud. I'm going to nip that adrenaline in the bud. And that's why I have not had a panic attack in 25 years, is because I don't let it get out of control. I never let it get out of control. I know what to do, and it works. It works. And so, if you allow those negative thoughts to continue, you are perpetuating fight or flight. You are scaring your brain into fight or flight. And again, we're not saying it's a mental illness. They're calling it a central nervous system maladaptation. It's a central nervous system maladaptation. Your brain has gotten habituated into fight or flight. But mind-body medicine, 20 days of mind-body medicine will reverse the damage of 20 days of bullying and abuse or pain. So this is where mind-body medicine matters. It matters. It works. But of course, you, like the rest of us, you're like going, don't freaking talk to me about mind-body medicine. My bladder's screaming at me. I want to focus on my bladder. And that's logical, because that's what I did. But if you have super sensitive skin, if you have a wicked sense of smell, if you can smell things that other people can't smell, and smells drive you crazy, that's a brain function. That's a central nervous system function. Your central nervous system is involved, if not driving, a lot of this pain, even if you had endo. So we have to make calming the nervous system part of our treatment plan. Yes, you're still going to be doing physical therapy to relax muscles. Yes, you're still going to be doing some things maybe to relax your bladder. But if you allow your central nervous system to spiral out of control, then you're going to be struggling with a lot of extra pain that you don't need. The brain processes pain in 3 ways, the 3 levels. Let's say your bladder's hurting. It goes from your bladder to your spinal cord. It goes from your spinal cord up to your lower brain. Your lower brain is the gate. It only lets the most important pain message through. So if you step on a nail, you can damn well bet that's going to hurt like hell. That's going to go right through the gate. But if you get bit by a mosquito, it might not go through. And this is the first place that you can interfere with pain, because you can create a distraction. You could, for example, slap your thigh like this, put a TENS unit on your thigh. I flew to London in a severe flare doing this. That I'm giving my lower brain something else to pay attention to besides a screaming bladder. Distraction, right? Okay. But let's say the pain is more intense. You stepped on the nail. Now it's going to go to the midbrain. The midbrain establishes context. Is this good pain or bad pain? Okay. Well, if you stepped on a nail, then let's see. How did they say that? Pain that is accompanied by laughter, like you're riding a roller coaster and you get thrown against the side of the roller coaster car. Okay. The context is good. You're laughing. There's no threat here. You're just riding a freaking roller coaster. But if you were walking on the beach and you stepped on a jellyfish or you stepped on a nail, it's a whole different story. That's severe pain, and that's going to be intensified by the midbrain because your brain thinks, "Oh my God, her life is at stake. Oh my God, what happened? Is her foot being cut off?" Right? I mean, it's a super intense reaction. And then once it leaves the midbrain, it goes to the upper brain. And it's the upper brain that determines the physiological response to that pain, whether you're going to start jumping up and down on one leg, whether you're going to pull out the nail, etc. So there's a lot of primitivity happening. It's primitive. It's just very primitive. The pain response is very, very primitive. The stress response is very primitive. And we have to give that brain good sensory information that is comforting and hopeful. And that will help calm things down. So, I Spy, guys, you got nothing to lose. Do I Spy, and especially if you've got children in your family who are going through stuff, there would be nothing better than sitting on your front porch with a child who is struggling in school and saying, "Honey, let's just forget school for a moment. Pick anything out here. What's your favorite thing that you're looking at right now?" And go through I Spy with them. What's your favorite thing to eat? What do you love to smell, honey? What do you love to smell? What do you love to taste? Let's get that brain into good sensory information, and it calms collectively the entire central nervous system down and the pain response down. Amy says, I had a physical bully. I was sexually abused many different times and physically abused in my home. I actually wet the bed. Yeah, exactly. Amy, honey, the same, pretty much something very similar happened to me. And I've shared that story. I grew up in a neighborhood where one of the kids my age was very, very mentally ill, and he ended up raping and murdering my neighbor. And I was one of his victims. And so your brain was in fight or flight from day one when this began. And, the single most important thing I want you to remember from me right now is that this is not your fault. You have done nothing wrong. There is no shame. There is no blame in what you have gone through. You were a victim. I was a victim. And it said nothing about me, and it says nothing about you, and it says everything about the people who did this to us. This is a great quote. It's not what's wrong with you, it's what happened to you that matters. And I'm so, so sorry that you as a child were not in a safe home. I'm so sorry that you went through that. But remember, like um I was listening to Joel Osteen, and I know some people don't like Joel Osteen very much, and that's okay. I do. I happen to like some of the things. I turn them on in my car. And one of the things that he said is, rather than dwelling on somebody who hurt you, rather than dwelling on somebody that interfered with your life, um, think about it a different way. Because you went through that experience, because you rose above that experience, it actually kind of made you stronger. Like I think about what I went through as a kid, and I think about, I mean, like there's a part of me that's angry that it happened, that my life was irrevocably changed, that it was very, very hard. It has been very hard for me to trust a male figure because I was hurt so badly. And I'm not the only one. I mean, this is common. And in my life, because that's been a hot button for me, um, when I encounter that from other male figures who can be demeaning and insulting and hurtful and harmful, um, I'm prepared. I'm prepared. And I know it's not me. I know it's them every single time. I mean, if somebody gets off on hurting other women, sending them hate mail, whatever, whatever, that's not me. That's them. They're messed up big time. You can't fight, I don't know. Anyway, I'm so sorry to every single person who went through what we went through. My tennis partner was raped, gang raped in college, and it's just the trauma of things like that are just tragic. But you know what? We're tough bitches. We're tough. I'm tough. I will never, ever let that happen to me again without a fight. Never. I worked for the feds for a while before I went to grad school. And I worked out of a Social Security office by San Quentin Prison. We had very violent guys come in to the office, very seriously mentally ill, violent. One guy brought his chainsaw in, and fired up in the reception. Then the FBI officers always came up and rescued us. Well, man, they finally trained us. I went through FBI self-defense training. It was grisly. I'm really glad I did it. I won't get into it, but let's just say it was pretty good. So you have never been more prepared to deal with whatever happened to you than you are at this very moment, because you are truly one day older and one day wiser. The abuser's gone. We have a new life. We're not going to dwell on the past. Let's not live in the past. We got today. We got tomorrow. We got things we want to do. I refuse to live in the past like that anymore. I don't think about that unless I'm talking about it. I am focused on today and tomorrow. What can I do right now to feel better? What can I do tomorrow that will help other people? Because I believe in service. All right. Deborah says she has overactive bladder, many health issues, as well as vulvodynia that's off the charts. So, Deborah, remember with vulvodynia is a superficial irritation of the nerves in the vulva, for lack of a better term. Many times the vulva looks fine, but it will feel like you have the world's worst yeast infection. For me, with my vulvodynia, it felt like somebody had used sandpaper to scrub off all my skin on my vulva. That's how my vulvodynia used to feel. And so with the vulvodynia, you're going to be focusing on a couple of things. Number one, we want to calm those nerves down. And that means that, you might not be wearing underwear. You're not going to be having anything that's going to be touching that skin. You're going to be reducing any chemical trauma, because that skin and the nerves in that skin are very, very vulnerable. So you got to look at your chemicals that touch that area. Fabrics, your laundry detergent should never be a big mass market brand like Tide. You really need to do something like 7th generation free and clear, which is what I do. Always rinse your underwear twice. You cannot use fabric softener. You cannot use anything in your dryer. We got to reduce any chemical contact on that skin. You also have to look at mini pads. Be very careful with mini pads if you're wearing mini pads every day, because mini pads suck the natural moisture out of your skin, and that moisture serves a purpose. It protects those nerves. Mini pads also can have a lot of extraneous chemicals, which can really irritate that skin. With your bath soap, make sure that you're doing a very, very simple, clean bath soap like Dove for sensitive skin, which is the one I use, or Basis. I think Dove is better because it's not too drying. But what you can't do is things like Iris Spring or shower gels, things like that. You got to be really careful with that stuff. You might find soaking in a bathtub with Aveeno bath soak. Aveeno makes wonderful oatmeal-based bath soaks. That's very good at calming vulvodynia pain. Another thing you can do is, when you've got super sensitive nerves on your vulva, urine hurts when you're peeing. It's like, ow, 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 right? And sometimes your urine can feel really, really hot. When I went to a vulvodynia support group meeting in my 20s, this group of older ladies took me under their wing, and they explained the power of the perineal wash bottle, because toilet paper will not get the chemicals from the urine off of your vulva, but water will. And so the rule that during any active vulvodynia flare is always rinse yourself off with room temperature water and then pat dry, because the water serves a purpose. It gets the chemicals off your skin, which are triggering those nerves. And then also understand that, again, cause and effect. The vulva pain is the effect. What's the underlying cause? The underlying cause could be estrogen atrophy, but it can also be very tight muscles. What happens when you've got super tight pelvic floor muscles is those muscles squeeze the blood vessels, and you end up with ischemia, oxygen deprivation. And so vulvodynia has long been linked to very, very, very tight muscles in the pelvic floor, especially if you have perineal pain, because the perineum, which is that flap of skin between the vagina and the rectum, and that's where my vulvodynia was the worst. Oh my God, it hurt like hell. And I never understood why it was the perineum that was like off the charts painful. And Dr. Weiss explains why in this book, Breaking Through Chronic Pain, that immediately above the skin in the perineum is something called the perineal body, which happens to be a muscle attachment point. That there are basically 4 muscles that all attach right above the perineum. And if one of those muscles are tight, bam, you're screwed. Your perineum's going to start to hurt. And so if we look at this picture, so here's your vagina, here's your rectum, and these are the muscles immediately above the skin. Look, there's your perineal body, and look, whoa, muscle tension point. So with vulvodynia now, they're really treating very successfully a lot of vulvodynia patients with pelvic floor physical therapy. And of course, your skin matters, estrogen atrophy, all that sort of stuff. Amy says, I absolutely agree. I'm sad that people chose to hurt me, but I'm grateful for the lessons I have learned. And that's, Amy, isn't that really the gift here? Like, the gift of IC and pelvic pain, and it's weird that you think of it that way, but it's true, is that we will never, ever walk away from somebody with pain like this, ever, because we know what it's like to suffer in silence. I firmly believe that a woman who has IC and has a baby will make them a better mother, because it teaches context and it teaches compassion. And the gift of going through this is that maybe the God-given gift of going through this is that perhaps in the future we will be able to help somebody who's gone through that, right? That's how I justify kind of the stuff that I went through, which was rough. Rough. Deborah says she had no coffee, no tea, no cheats in 20. Girl, you're better than me. You're better than me. I think everybody cheats at one point in time. I mean, I've cheated, but I've learned my lesson. I mean, I don't want to have bend over and scream or cramps from IBS, so I do not eat chocolate, and I do not eat oatmeal, and I haven't for 25 years. Then I won't do it. And I'm so much better. I've learned my sensitivities. It's okay. That's not a disease. That's being sensitive, Hello, redhead. We are super sensitive. Redheads are interesting because it actually influences how our brain interprets pain. And we have I think a lower threshold for pain. Like I have to wear, I mean, it's interesting that I can wear this shirt because it's the seam right here, the seam right here that sometimes really gets me. Sometimes I have to put tape over it. My skin is so freaking sensitive. It's ridiculous. Wanting One Angel says, I don't understand one thing. If blood flow is being cut to my bladder, how come I'm able to urinate? Well, think about it this way. If your bladder is normally infused on a daily basis with 24 units of blood, and it only gets 10 units of blood because of tight muscles, um, uh, will your bladder be healthy? And the answer is it won't be able to heal as quickly if it doesn't have good nutrition and good oxygenation. Um, I was reading a study that talked about, I think it was pelvic congestion syndrome, where they were actually measuring very good measurements on the quantity of blood that was being perfused through the area. And it was, yeah, there was a class on it last weekend too. So an interventional radiologist came to the International Pelvic Pain Society, and he talked about pelvic congestion syndrome in a different way. Like pelvic congestion syndrome is the equivalent of varicose veins in your pelvis. You've got big veins in your pelvis that blood is pooling in. And so the number one symptom of pelvic congestion syndrome is heaviness. Like as the day goes on, you get this heavier and heavier and heavier weight that you're carrying around, right? That's what it feels like. Anyway, he brought these oh gosh. Well, he brought sonograms and he showed it how they were measuring the width of the veins. But what he really showed is what happens when veins overlap each other. That if the vein on top is super big and heavy, it's literally squeezing the vein underneath it. And so the vein underneath it, or the artery underneath it, cannot deliver the blood supply it needs. So one side of the body would have these massive engorged veins, while the other side of the body, the veins were tiny because they just didn't have good blood supply. Thank you for the 50 stars, Terry. Really, really appreciate it. And you guys, if any of you find these meetings helpful, please consider coming on over to the IC Network and becoming a subscriber. You can get our magazine, the IC Optimist. Our fall magazine is almost done. It will be at the printer this week. I've been doing that for 18 years now. We have several writers. We always do a Meet the IC or pelvic pain expert interview in our magazine, along with a variety of research-based articles as well as self-help articles. Our fall magazine is, let me tell you the stories in our fall magazine. Here, hold on. Let's see here. I've got to go to publications in development, 2021 fall. Okay, so we've got the bladder regeneration study, COVID-associated cystitis, Meet the IC Expert with Beth Shelley, 10 tips for dealing with IC at work, the latest research, a big article on vulvodynia, as well as a big article on ways to make money and bring income in while disabled. So that is in our fall 2021 IC Optimist. There's also a diet article on our favorite breakfast food that's completely bladder friendly, which is pancakes. And so we've got several different recipes for different types of pancakes in there. So come on over to the IC Network, sign up for our free newsletter. If you do that, you'll get our 40-page flare management guide, which I'm in the process of rewriting. And of course, we have our new book, IC 101. It's not just a bladder disease. That is available on Kindle for $9.99. You can get it in print as well on Amazon or in the IC Network store. Now, I've decided that I'm going to I also want to feature at least one success story or a couple of success stories. I'm going to do Julie's story again because Amy, I think you'll relate to this. Okay. Well, let's see. Hold on a sec. Maybe not. Let's see. Because I just did that one last Thursday. I want to find a couple of good success stories for you guys. Okay, here's a good one. They're all good. Okay. Kira came to me at the age of 34 complaining that for about a year she'd been urinating every 1.5 to 2 hours during the day and 2 times during the night. Though considered symptomatic, this frequency is moderate relative to what many other patients experience. What made it intolerable was the intense, quote, bladder and lower abdominal pain, 8 on a scale of 10, that accompanied urination and lasted for approximately an hour. Prior to the onset of these symptoms, she had occasionally gone up to 12 hours without voiding or without urinating and had experienced no problem. Kira's history included many musculoskeletal issues dating back to high school when she was involved in an auto accident. Low back pain began at the age of 21, requiring periodic adjustments. Her neck also, quote, went out just before urinary symptoms began. Upon examining her, I found the 3 clinical signs for pudendal nerve irritation or injury. These were sensitivity to skin rolling and pinprick tests around the perineum and sit bones, exquisite bilateral nerve sensitivity when lightly touched internally, and in addition, the muscles of the entire pelvic floor and perineum were tight and loaded with trigger points. There were also internal trigger points in the hip rotators, both the piriformis and obturator, which, as I explained above, can compress the pudendal nerve. Internal myofascial release performed at the time of my initial exam relaxed the muscles around the nerves. This almost completely cleared the skin and nerve sensitivity. Just one treatment gave Kira dramatic relief in terms of her urinary frequency and bladder pain. And after 3 treatments, the nerve sensitivity to touch had diminished over 50%. She was able to sleep 7 hours without voiding, and the urinary urgency and pain were gone. Then, to reduce the tension around the pudendal nerves, I performed bilateral trigger point injections in the piriformis. After 2 months of treatment, the dysfunctional pelvic floor, perineum, and external hip rotator muscles had normalized, and the pudendal nerve had calmed down completely. And since then, Kira has done well. This young woman was lucky to have received appropriate treatment for her pudendal neuralgia and her associated muscle dysfunction within a year following the onset of her symptoms. Most patients suffer far longer than that before the cause of their problem is finally identified. And as I emphasized in chapter 5 and 10, if nerve injury is allowed to persist for an extended period, it can take a long time to resolve. In Kira's case, the internal segments of the piriformis and obturator internus muscles had indeed compressed and sensitized the pudendal nerve. This local dysfunction in combination with abnormalities reflected in her back and neck pain caused the pelvic floor muscles and the perineal muscles to tighten and develop an abundance of trigger points. Let's see, hold on. Okay, let's do one more. Let's do one more. Okay, and then we'll be done. And you see I'm squirming. I'm squirming right now because my left piriformis is not happy with me. Okay, Xandra. Let's do Xandra's story. Very recently, 33-year-old Xandra consulted me for the treatment of IC. 10 years prior to her appointment with me, she had developed urinary urgency frequency and urethral pain with voiding. At that time, she also had bladder pain with or without bladder fullness. And periodically, she also would get the urge to void, but would have difficulty doing so and felt like she couldn't completely empty her bladder. Given these symptoms, I was not surprised to hear that she recalled having voiding difficulty as a child. Antibiotics were prescribed for Xandra, even though infections were not found. Eventually, she saw a urologist who performed a cystoscopy and the installation of potassium chloride in her bladder. Both of these tests were consistent with interstitial cystitis. The prescribed treatment was dilation of the urethra under local anesthetic. Hello, talk about old, which was extremely painful and caused severe symptom flares. Other therapies, including Elmeron, Vesicare, amitriptyline, hydroxyzine, 6-DMSO installations, finally a cocktail of bladder calming medications every 6 months for 7 years. The installation of medication into the bladder, let's see, hold on. She told me that the catheterizations had been almost unbearably painful, that they had given her occasional bladder infections, and that her bladder had become so irritated that she was having difficulty holding solution in as required. In short, quote, the cure had become as debilitating as a problem it was intended yet failed to eliminate. However, over the years, there had been some improvement. When Xandra first developed her symptoms, she was voiding small volumes every 15 minutes. But with the above treatments, the frequency dropped to every 45 to 60 minutes and twice at night. She rated her current pain as being a consistent 4 to 5 on a scale of 10, but that occasionally it reaches 8 or 9. But nonetheless, she's taken no pain medicine. On further questioning, Xandra mentioned having pain in the sit bone area with sitting, like me right now, for as long as she can remember, that referred to the tailbone and the back of the thighs. She never told anybody about this because she thought it had to do with, quote, the way I sit, and was unrelated to her urinary complaints. She also reported a past history of bilateral Achilles tendonitis and indicated that she was presently dealing with low back pain and neck pain. My external examination, you guys, I'm reading from Dr. Jerome Weiss, so this is not me. This is Dr. Jerome Weiss. My external examination revealed extreme sensitivity over the sit bones and perineum with skin rolling and pinprick tests. I also noted bilateral Morton's toe, many trigger points in the hip rotators at their attachment to the hip, trigger points in the quadratus lumborum muscles to help stabilize the pelvic core, and trigger points in the lower rectus abdominal muscles. Internally, Xandra had exquisitely tender pudendal nerves with trigger points in both muscles. The findings I've just enumerated all seem to fit the picture of pudendal nerve entrapment as the core problem and not interstitial cystitis. After I performed internal myofascial release to relax the pelvic floor muscles and mobilized her pudendal nerves, Xandra experienced temporary relief. However, because the pudendal nerves were still very tender, I also performed bilateral nerve blocks. And here it is important to note that she had more pain in the left buttock when sitting, and the left nerve was the most painful of the two. Hello, this is me. It is also important to emphasize that pudendal nerve blocks with anesthetic and cortisone are both diagnostic and therapeutic. That is why I perform them at times of the intake evaluation. If the symptoms resolve for a period after the block, it means the pudendal nerve is causing the problem. In Xandra's case, the pain was sitting and all the urinary symptoms disappeared for 9 hours. At that point, urinary frequency recurred, but there was no bladder or urethral pain until the following day. 2 weeks later, the urinary symptoms reappeared, but their intensity had diminished. As for the pain with sitting, it had not returned. All of the above evidence clearly points to pudendal nerve damage as a major source of Xandra's, quote, IC symptoms, including the bladder and urethral pain and the urinary frequency and difficulty voiding, as well as pain with sitting. Over time, I expect Xandra's symptoms to be dramatic, greatly improving her quality of life. So by now, you should understand that the bladder is not really to blame for most, if any, of the symptoms associated with the urinary syndromes we've been investigating. You should also know that the pelvic floor muscles are most likely to lie at the root of the problem, though the pudendal nerve is also the possibility. And you should be aware that many chronic long-term urgency frequency patients and most IC patients are experiencing central sensitization. As I have emphasized, central sensitization is a systemic condition that poses a significant challenge. The entire gang of perpetrators, including the disgruntled elements that keep punching up the nervous system, must be rounded up and rehabilitated to give the traumatized system the vacation it needs to heal. Studies indicate that when a vacation is granted and painful input to the central nervous system is interrupted for a period, nerve functioning reverts to normal. All right, so listen. Again, I cannot tell you any more than what I've done. This book is Game Changer, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss, and it's free on Kindle Unlimited. No excuses. Get it, read it, learn it. You got to understand your body, okay? Deborah says best broadcast ever, Jill. Hey man, we did pretty good on Thursday too, I gotta say. All right, now I gotta listen to my body because my left butt cheek is throbbing right now and starting to vibrate. So that means it is time to say goodbye. So I wish you well. Here's your homework for 15 minutes a day. I need you to do something to calm your soul and your spirit. I'll probably lay on my couch and listen to something. For 15 minutes a day, I need you to do something for your bladder or your pelvic floor. Get down on the ground and do your stretches. I have to do that today. I haven't done that yet. Make an IC-friendly meal. That's good. For 15 minutes a day, I need you to do something to work on your noggin here. Let's get that knowledge level up. Again, come on. You can read a couple of pages of this. I mean, this is you got to go back to school, hun. You got to go back to school. You got to learn all this. Every time I read it, I want to read it every single week. I mean, I get new stuff out of this all the time. And then last but not least, for 15 minutes a day, I want you to laugh your ass off. Let's get some laughter in there. Come on, just do something funny. Get some friends together. Play Jackbox TV if you haven't done that before. Watch some videos, watch some TikTok, although I don't really like TikTok that much, although I think it's funny and it's quite addictive. But let's get some laughter up there. Laughter minimizes pain. So let's do that. All right, my friends, as always, if you find this helpful, come on over to the IC Network and maybe become a member or buy something in our store, which helps pay for me to do this for you. And I'm happy to do this for you. I love to do this. I always want you to remember my job is to open doors, open windows, give you some knowledge, then kick you in the butt and get you back to your doctor. Because I do not give a medical advice. All my job here is to try to educate you, get you to ask some questions, and then get you back to your doctor with better questions. Alrighty? And Amy Sue on Facebook, if you email me, icnetwork@mac.com, icnetwork@mac, M as in Mary, A as in Apple, C and Charlie.com. I would love to send you my Winter 2021 magazine, which goes over all of that research about the chronic overlapping pain conditions and the endo and all that sort of stuff. I would really love to give that to you for context so that you can understand that a little bit more. And please, everybody, carry hope in your heart. Again, the single most important thing I want you to remember right now from me is that this is not your fault. You have done nothing wrong. There will be no shame. There will be no blame. You are not damaged goods. You are somebody who deserves care. You deserve love. You deserve kindness in your life. And you get what you give. So we want to make sure that you're being kind to the people around you too. And especially to your medical care providers because they are breaking under the strain of COVID right now. It is what they are going through right now. Boy, I got to tell you, it's really heartbreaking. So just be safe, be kind. And I will see you guys again next week, hopefully, next Thursday. And wish me luck on my dad's 99th birthday. All right? Okay, I'll see you later. Have a good one. Be well, be strong, be confident, be informed, and be bold. Let mighty forces come to thy aid, right? Okay, talk to you later. Goodbye, YouTube.